It is 9 o'clock, and we are going to go ahead and call the Bob Bethell Joint Committee to order. We do have I know Representative had to run down and grab something. We'll be right back. I'd like to welcome Senator Fagg to our committee. He is filling in for Senator Stephan, and I believe we also have several representatives and senators attending online. So hopefully we do have a quorum that we can go ahead and get started. Just a little bit of housekeeping if we can. Whenever you come up to the microphone to speak, please restate your name and who you are representing before you give your testimony. And when we start with the 905 presentation on KanCare from individuals, providers, and organizations, we have quite a few testifying, so please keep your verbal testimony to 3 minutes or less. Marisa will be keeping a time card for you, so she'll let you know when your 3 minutes is up. So with further ado, we'll go ahead and get started. And first up, we have Matt Fletcher. He is the Executive Director of InterHab. Matt, welcome to the committee.
Thank you very much, Senator Hildebrand and members of the committee. I hope that you're able to hear me this morning through the remote connection.
We are.
Okay, excellent. I'll be brief in my comments this morning. First, I want to thank this committee for its continued work in examining human service issues within the state of Kansas. That leadership is greatly appreciated by the providers who do the work in communities across the state. And on behalf of the members of InterHab, we certainly appreciate your continued focus on Kansans with intellectual and developmental disabilities. We also appreciate the work done this session by the Kansas Legislature to include very much needed new funding for the IDD system in Kansas. The new funding is for the remainder of this fiscal year and for next fiscal year as well. And again, we just really appreciate the work that has been done on behalf of this system by the Kansas Legislature this year. I've included written comments for the committee regarding the IDD waiting list. These comments are very much similar to those that I prepared for the Senate Public Health and Welfare Committee a month or so ago when it did a deep dive into this topic. We are looking forward to an examination of the IDD waiting list later on this year, and we are excited to partner with KDADS and with other stakeholders to be able to finally begin to examine the IDD waiting list and develop a strategic roadmap for its elimination. I would encourage you to review my written comments for details on the IDD waiting list, its history, how it has grown through the years, and the current predicament that we find ourselves in. My Associate Director, Nick Wood, will be following up, and Nick has been looking at some service alternatives that could be brought to bear to assist the state in resolving the waiting list. And so the members of InterHab are very much interested in how we create those new types of service options for Kansans with IDD who are waiting to receive service. And so much so that we will, in about an hour or so, be convening a first meeting of InterHab members for a special work group to begin crafting potential solutions for consideration by legislators and stakeholders later on this year. So we're excited to get this work group off the ground and utilize the expertise of InterHab's members to begin coming up with some ideas that then could be considered later on this year. With that, I'll go ahead and stop, Mr. Chairman, and if there are any questions, I'd be happy to answer them.
Matt, thank you. Can you, will you be available to let all the conferees speak before we go to questions? Okay, thank you.
Yeah.
Okay, thank you, Matt. Just for our colleagues on the House side, what Matt referred to, what we did in the Senate Public Health and Welfare Committee. We had a one-day hearing on the IDD waiting list, and one of the things that we came up with out of that was we requested for KDADS to work with interested parties that are on the waiting list to evaluate it and come up with a roadmap to get that from where it's continually growing to where we eventually get to zero. We know it's a long haul, but we have to start somewhere, and that was the task that we gave to the interested parties and KDADS. So, Matt, thank you for touching on that. Our next conferee is Nick Wood. He's the Associated Director of InterHab. Nick, welcome to the committee.
Thank you, Chair Hildebrand, members of the committee. Just making sure I was got my video started. So I heard Matt talking a little bit about alternatives that other states have used around to eliminate waiting lists. My testimony that I hope you have in front of you is around crisis services. We've been discussing this a lot with members of the legislature and KDADS for quite a while. I think that everyone understands that there's a need for this. I wanted to, in my testimony, kind of lay out the two bills that are active with the legislature right now that would help us address this very large gap in our services. So, there's House Bill 2281. That's that 988 toll-free crisis line. I've learned a lot more about what's happening. Of course, for anyone who is a member of House Health and Human Services who heard that bill on the House side, you're going to be familiar with this. But the FCC in 2020 passed a rule saying that states would be implementing a 988 suicide prevention crisis line using fees that are assessed to phone plans. So the plan is for this to go into effect July 2022. The federal law requires telephone providers to initiate this. So when you call 988, you get to talk to someone at least for suicide prevention. The program would also be pretty ideally suited to crisis intervention services and providing the backbone administratively for those services. And so in my testimony, I also included a description of House Bill 2373, which is based on a model that states have been adopting the last 10 years really across the country for providing crisis intervention services specifically for people with intellectual and developmental disabilities. But I think the neat thing about looking at those two bills side by side is you can, as far as the program design goes, which is something that will have to take place via stakeholder meetings in the future, but you can kind of see how they work together. In Kansas, it would be very nice for us just to have one toll-free line that somebody can call for their suicide prevention and crisis intervention needs. So that's, it's a program that I know that there's some sort of ongoing considerations on the part of policymakers with these things, but I can promise you, as somebody who's worked with the system for a long time and has specifically worked with a lot of people who've fallen through those gaps in our system, this would have direct impact on a lot of people's lives. It's probably maybe the one service that I'm aware of that people feel the most in need for, and almost in these situations desperate for. So it would really be something for Kansas to adopt a program like this. Matt also had, he mentioned alternatives to waivers. To kind of traditional waiver services that states have adopted to eliminate waiting lists. And a lot of those programs out there are really focused on the person-centered needs or family-centered needs. The main difference between them and kind of what comprehensive waiver is most states will keep a comprehensive waiver, but then they'll also have another set of services, usually through a waiver, that at a minimum do not include 24/7 care. So if you have any questions, I'd stand for questions.
Nick, thank you. And will you be able to hold for questions until after all the conferees have had an opportunity to speak?
Yes, I can actually, Chair, we here at Interhab, we have a team meeting to discuss the waiting list. I think, so either Matt or I will be here.
Okay, thank you very much.
Thank you, sir.
Committee, next we have Amy Heighton. She's the Executive Director for the Topeka Independent Living Resource Center. Amy, welcome to the committee. And if you wouldn't mind just restating your name, please, for the...
There we go. Thank you, Chairman Hildebrand and members of the committee. My name is Amy Heighton. I am the Executive Director of the Topeka Independent Living Resource Center. I've also submitted written testimony. I won't obviously rehash that. However, I will sort of touch briefly on it. The two items that I have in my written testimony is, of course, an endorsement of continued support through the budget negotiation process for the 300% increase of the protected income level to get to 300% of supplemental security income level. That's money that would go in the pockets of disabled and aging Kansans and help them with their daily living expenses. Additionally, our agency has reiterated in our testimony the request for the state to engage in an Olmstead planning process, which would develop a comprehensive, fully functioning plan for implementation of long-term services and supports in an integrated setting for disabled and aging Kansans. Both of these requests have a little bit of lift under them that they didn't previously have thanks to the first federal relief that has been dedicated to home and community-based services through an enhanced federal Medicaid match that happened in just the last budget reconciliation process. And so we're hoping to see the support of this committee for a dedication of those funds to those types of programs, those types of initiatives that will go directly to helping disabled and aging Kansans who are using home and community-based services or who could use home and community-based services to avoid going into congregate facilities or who could return to their homes from congregate facilities. We shouldn't have been surprised that as these funds were announced, that immediately organizations representing providers in congregate care facilities have been sort of circling and trying to find ways to access those funds, notwithstanding the fact that PPP, increased Medicaid daily rates have been made available to those organizations, and billions of dollars have been made available through CMS for infection control in those facilities. So we're requesting that this committee, as an oversight committee, express their support in ensuring that these enhanced federal matching Medicaid funds that are for home and community-based services are used to the benefit of disabled and aging Kansans and the workers who support them, in using these services to remain in their homes where they're safest, to use these funds to ensure that they don't go into congregate facilities from hospitals, and to expand programs that make the option available on a broader basis for people to leave congregate facilities and return to their homes. Thank you. Thank you for your attention.
Amy, thank you very much for your testimony. Committee, next we have Haley Ordone. She's the chairperson for the Kansas Adult Care Executives. Haley, welcome to the committee.
Good morning, and thank you for your time as always. I'm Haley Ordone, here with Kansas Adult Care Executives. We represent the providers for adult senior care living, directly the administrators and operators in that industry. I know time is always of an essence here, so I will try to make my testimony brief. I hope that you have the written in front of you. A lot of things to reference, lots of things to thank you guys for and all of your efforts, and we greatly appreciate that. I do want to take a little bit of time to explain certain things that we're in opposition to and why, and to give you, frontline details of what we're facing. We do have, House Bill 2062. The thing that we want you to realize regarding this one is that we answer to so many different entities. We answer to KDHE, to KDADS, to our local county health departments, the commissioners that oversee them, but also to CMS. So if we have something on the state side that is not in line with federal, we're going to get it from one of two ends. And we constantly walk around concerned, watching over our back of who's going to come and fine us for doing what someone else told us to and not listening to them. So that when there's a conflict, we get put into a lose-lose situation. The other thing I really want to focus on for your attention is a lot to do with our gas bills and electric bills that we had. We couldn't exactly titrate our usage down on those. And I did reference here in the testimony, one of our providers here in Topeka alone, their normal bill is $2,000. They got their bill recently, $112,000. They have no idea what they're going to do. So please, in all of the things that you guys do, please take attention to that those are some things that we're facing also. On vaccinations, we have had a great rollout. We have had great progress with that. We need to be looking down the road at what our plan is for oncoming staff, for new residents. We don't seem to have a solid pathway for how we're going to continue to maintain this. Some people are having success with their local county health departments. Others aren't. Others are trying to go through their pharmacy providers. There's just not a streamlined process for this, and we're trying to get ahead of the game to prevent a problem before it happens. Last, I want to draw your attention. You hear me advocate all the time in favor of funds for staffing, the pass-through. I want you to reference the graph that I have. I believe it's on page 3 of the printout. Before this pandemic, we were already facing staff shortage in healthcare. After this pandemic, we're facing an even worse one. And here's a lot of the reasons why. We have advocated for there to be some parameters for what staffing agencies can charge us. We've referenced it before, that they essentially poach our staff away from us and sell them back to us at much higher rates. Well, these are actual details of what those higher rates are. We've done the math, and look, there's over 200% difference in those wages. We're not sure how we're supposed to sustain that. I thank you guys all for your time, and I'm happy to stand for questions at the appropriate time.
Haley, thank you very much for your testimony. And just to touch on something you had discussed, gas bills, utility bills. We did pass legislation that goes into effect May 1st that you can apply for these facilities can apply for a low interest loan. It's not a fix, but it's a Band-Aid that will help them alleviate the upfront costs. So you might look into that on May 1st. Committee, next we have Leslie Anderson. She's the Executive Director of Kansas Association of Area Agencies on Aging and Disabilities. Leslie, welcome to the committee. Leslie, are you with us online? Okay. Committee, if Leslie does come online later, we'll go back to her. We'll now move on to Roxanne Heidecke, co-owner of Case Management Services, Inc. Roxanne, welcome to the committee.
Good morning. Thank you. My name is Roxanne Heidecke. I have been a case manager for almost 30 years for the IDD population, and I am the co-owner of Case Management Services. It sounds like Interhab has already spoken on the points that I'm talking about, specific things that happen on the front lines out in the community with the IDD community. So I've talked about the pay rates at state institutions. I never thought I would testify about this, but I have an individual in Parsons and have had some instances where we have grave concerns about his care there. And in talking to the people at Parsons, it was noted that their pay rates are less than KNI and Osawatomie. So I would like us to look into that. Everything's interconnected. Really, the pay rates for individuals that serve this population is the most important thing that we do. So to ensure we get good staff, and there is a staffing shortage. It's been a bad year, but if we paid individuals that serve our individuals well, then they would be better taken care of. The next thing, which kind of touches on InterHab also, is the crisis process. I have listed in my testimony the inconsistencies between the CDDOs, things that they need for the crisis, KDADS, and the MCOs. So for some reason, it's quite a complicated process. I do remember back in the old days when we would write a crisis request, present it to the CDDO, and it would go to the state, and we could get crisis funding within a few days. That's not the case anymore. So I would like us to look into making a crisis request process that is globally good for the CDDO, the MCOs, and KDADS, but most importantly for the individuals that are on the waiting list going into crisis and not being able to get crisis funding and assistance that they need. My last thing that I wanted to talk about was just the MCOs. All three of them have a different process for their home mods. There is nothing written anywhere that lets us know as case managers what the process is and what their guidelines are. So I would just suggest that we have all three MCOs have that information, because we do have individuals that are aging. They're not doing as well as they used to be doing, and so are in need of home mods. And for it to take a few months because they changed the process in midstream, it's not fair to the individuals served. I think that you have my testimony hopefully in front of you, and if you have any questions, I would be glad to answer them.
Roxanne, thank you very much for your testimony. Committee, next we have Sean Gatewood. He's the co-administrator for KanCare Advocates Network. Sean, welcome to the committee.
Thank you, Mr. Chairman and members of the committee. I'm happy to be here once again today. I want to talk about just a couple of brief issues. One is our continued support and advocacy for increasing the protected income level for all populations and the HCBS and PACE programs to the 300% of SSI, as a previous conferee had discussed. I think that it's important to take a good hard look at that, and the reason being, it helps to keep people in their homes. And I think that given the pandemic, I think that having people living in their homes is especially important, but just in general, allowing people to keep more of their own money to live a more fulfilled life, retaining as much individual liberties as they can, should be an admirable goal for all of us. Also, in light of the new revenue estimates and the state's sort of fiscal condition, I think it would be important, and the sort of one-time monies and the new legislation from Washington, I think that it would be good to sort of take a look at rebalancing and maybe taking a very deep dive into what the priority in health is. Right now, you know, the service that's absolute is facility care, and I think we need to set the goal to having folks age at home as much as possible. Again, retaining as much freedom, individual liberty as they possibly can, I think is something that we can all agree on. In doing that, we need to take a very good look, and particularly when we talk about one-time money, taking a very good look at all of the waiting list situations. I think this would be a time to do that. We have the IDD list, as previously discussed, very important. There's also the PD list. We have, we don't call it a waiting list, but we have the autism waiver, which we have a couple hundred children under the age of 6 that are not being served in the state right now. And that would be life-changing for them for the rest of their life. And then we're sort of on the razor's edge of having a brain injury waiting list. And so between all of those, if we want the sort of best outcomes for all of those populations, we need to study that and get as much buy-in, not only from the legislature or the governor's office or the advocacy community. It's a big, big problem that we need to sort of chart the course and all stick with together over time. And that's a difficult task. That's why it's frequently kind of backburnered. But it's a worthwhile one, and we appreciate all the effort that seems to be, the interest that seems to be ginning up right now in that. So thank you very much, and I'll be here for questions at the appropriate time.
Sean, thank you very much for your testimony. Committee, next we have Joan Kelly. She's the Vice President for the Kansas Neurological Institute Parent Guardian Group. Joan, welcome to the committee.
Good morning, Chairman Hildebrand and members of the committee. My name is Joan Kelly, and on behalf of those unable to advocate for themselves, thank you for the opportunity to present today. As co-guardians for our grandson, my husband and I endured many community system failures, spanning over a period of 10 years. Our loved one is now 30 years of age, yet functions continually at the age of a 2-year-old, and he has lived at the Kansas Neurological Institute since 2008. Our families are forever grateful for the continuum of care at KNI, and I'm pleased to inform the committee that there has not been one single COVID-related death at KNI since the onset of this pandemic. There is a new attack against our loved ones, and many here are already aware of this congressional legislation that will come down the pike and will affect long-term care services in every single state across the nation. It's called the HCBS Access Act, and it's based on the assumption that people receiving services at places like KNI are somehow there against their will. It would amend the Social Security Act, promises to eliminate waiting lists, and relieve the state's financial burden. The disparities in funding, however, would undermine the protections already clarified under public law and will create a greater discrimination against the weakest members of society. While focused on free community care, this legislation will, in effect, it will dismiss placement for individuals with the most complex conditions and remove incentives for states to continue to provide centralized care at facilities such as KNI. Excuse me. Over the last 20 years, legislators have and continue to hear from numerous entities for increased HCBS funding. Only a small percentage of these professionals who bend your ear have actual firsthand experience in the 24/7 care of profoundly affected individuals. Families and guardians have intimate knowledge of their loved ones and are in a superior position to choose appropriate supports for them. Most families, unfortunately, are hindered from even coming here to present before the committee. They are exhausted from shouldering 24/7 care, since increases in HCBS funding are often allocated without addressing or relieving the 20-year direct support staff crisis. Best practices and quality measures are terms used by those who routinely testify before you, yet alarmingly, they often exclude the most critical data of abuse, transfer trauma, and deaths in community settings. The attached document for committee review refers to community tragedies and the unspeakable number of deaths occurring across the country. One might ask then, at what point can the label of genocide be put to these impacts?
In closing, I'll just say that the aggressive nature hidden in this proposed legislation, which I'm sure you'll hear more about in the future, is striking, as it will lead to the further dismantling of the safety net and care that our loved ones require. Therefore, I am compelled to warn, respectfully urge this committee to refrain from any misunderstanding and support the HCBS Access Act as drafted. Thank you, and I stand for questions.
Joan, thank you very much for your testimony. Committee, next we have Margaret Farley. She is the Executive Director for Kansas Advocates for Better Care. Margaret, welcome to the committee.
Thank you, Chair Hildebrand. My name is Margaret Farley, for the record again. I appreciate the opportunity to testify here today on behalf of the members and Board of Directors of Kansas Advocates for Better Care. I will say at the outset that I think it's important that we continue to remember the lives lost and the lives ruined during the 2020 pandemic, which continues. We must not forget, we must continue to remember the lessons learned from the COVID pandemic in long-term care. I am concerned as an executive director of Kansas Advocates for Better Care that we still have far too many limitations in home and community-based services and far too many gaps in the quality of care in long-term care facilities and residences. Home and community-based services are the wave of the future, and that wave got a big kick after we saw what happened during COVID with something so basic as infection control in long-term care facilities. The funding for HCBS, the oversight, the accountability, and transparency in regard to the financing and quality assurance for all levels of home and community-based services and residential care services and institutional services, which are certainly necessary in some situations, as the prior speaker talked about. All of that has to be comprehensively coordinated and monitored. We are now dealing with monies that are coming, thankfully, from the federal government to help with the devastation of COVID in facilities. However, KABC is greatly concerned about how we are accounting for these dollars and how these dollars will be used. There are many corporations involved, many of them with very good intentions, many of them with very selfish intentions, and we need to watch where that money is going and keep track of it. It is the case that in Lawrence, within the last 2 weeks, a continuing care retirement community, Brandon Woods, has announced that it will be closing all of its nursing facility and skilled nursing facility beds. So all of those, that piece of that continuing care retirement community is apparently going away under current ownership. This was announced to many people who live in Brandon Woods through the newspaper. This highlights how we are continue to treat people who, older adults and disabled folks who live in long-term care institutional facilities.
Margaret, you're over the 3-minute mark, and so if you could just wrap up real quick.
Okay,
please.
Thank you. I just want to make a thank you and my apologies. I just want to make a pitch for staffing concerns right now are very, very bad. We also at Kansas Advocates greatly advocates for the 300 percentile percent protected income level. It is critically important to so many to stay in their home and where they are. It's absolutely necessary to have a successful program. Thank you, and my apologies for going over.
Margaret, thank you very much. Marisa, would it be possible, we've heard about the HCBS Access Act. Is there a way that we could get information and an update and status on that? Okay. All right, thank you. Committee, next we have Rachel Monger. She's the Vice President of Government Affairs for Leading Age Kansas. Rachel, welcome to the committee.
Thank you so much, Mr. Chair. I am Rachel Monger with Leading Age Kansas, and I'm going to start with a huge thank you to all of you in the legislature, but especially on this committee, for the support that you have given our members over this last year. It's through all of that, it's been a big source of comfort to our providers, knowing that you guys have worked so hard and have had our backs, and our residents, obviously the most important part, to get through this crisis. And it's even hard to overstate how grateful we are for the extra funding that you guys have given us and your support of our COVID liability bill. So we just wanted to say thank you so much for all of the work you guys have done. Did I just get emotional? Hopefully not. I'll move on. Even though we have, a light at the end of the tunnel, our crises aren't over. Our staffing, it does remain dire. And I know I've said this many times now, but even before the pandemic, our staffing was in crisis, and now it's just a truly desperate situation. I've started to hear from our members, even yesterday, who are freezing admissions because they don't have enough staff to properly care for them. They've now had to turn to temp agencies, staffing agencies, not just for nurses and nurse aides, but even for housekeeping and dietary staff now, which we've never heard before. The extra funding that we're getting from the legislature is super helpful in allowing us to maintain our wages and our incentives to keep the staff we have. And that's going to continue forward. Again, so grateful for our staff. I think we are in the situation right now where we now have money to pay for staff, but we're just not getting applications. And I'm really hoping we're going to see that tide shift as we get through the pandemic, but it is a really serious concern. And we know that for a long time, the issue has been wages, which is something that dogs all of our providers who primarily do Medicaid. Again, we hope that extra funding is going to allow us to push up our staff wages, even however temporarily. But there are long-term solutions that we have to find when it comes to the senior care workforce. And I know we're very, very happy the governor signed House Bill 2114 yesterday. And I think staffing is going to be a constant theme in a lot of those discussions we have on that task force. And we're eager to get started on those discussions. And I want to actually also second Ms. Ordoin's comments on the gas bills. Our members have started receiving those now. We've gotten calls, and we have referred them to the loan program and given them the contact for the AG's office if they feel like they should be filing a complaint. We're not really sure what else to be doing right now, but we do hope that the investigations and any possible remedies that may be out there for those gas bills proceeds quickly. So thank you very much, Mr. Chair.
Rachel, thank you very much for your testimony. Committee, Luann Kibbe has changed from oral to written only. So next we have Kathy Keck, a private citizen. Kathy, welcome to the committee.
Good morning. First, I think I should apologize. I apparently haven't been here in so long that I didn't realize the chair had switched from a sir to a sir, so I apologize. All right, thanks for allowing me to come today. My name is Kathy Keck. As you've heard in previous testimonies, so some of you are new faces, so maybe you don't know me, but I am a mom of 5 kids. My son Jacob's here with me today. 3 of my kids have significant developmental and medically complex issues. My youngest daughter, who has been to this committee with me before, is 5 years old. She has a tracheostomy and a G-tube and requires 24-hour care, medical care, to sustain her life. I want to talk about two issues today. First is, again, about specialized medical care, and the second is about network adequacy. So this is not my first time pleading with this committee to help my family and others like ours who are exhausted. Currently, my daughter is approved for medical care 7 days a week. However, 3 of those days are uncovered with nursing services. So that means, once again, my husband or I, or members of our family who are trained in her care, have to provide that needed medical care. Home and community-based services are meant to allow a person to receive essential services and supports to stay in their home. For the TA waiver in particular, this means instead of a child staying in the hospital to meet their complex medical needs, they receive these essential medical services in their home, which allow them to stay in their homes and out of the hospital. Could you imagine if you needed to go to the hospital because you had a medical emergency or concern and you were hospitalized inpatient, and the administrator came and said, hey, by the way, we don't have any nursing staff the next 3 days, so go ahead and call your family to come and help take care of you, and then we'll cover the other 4 days once we get staffing. That sounds absurd, right? But that's exactly what's happening to families like mine and many others across the state who don't have adequate nursing coverage to care for our kids, and yet we're trying to keep them in their home environments in the best possible situation. So I just implore you guys to raise the rate of specialized medical care to $48 an hour to allow providers to attract and hire qualified nurses to meet these needs. There's all kinds of awesome nurses, but the thing to understand is that children like my daughter aren't just your typical child to take care of, isn't your typical patient in the hospital. Her room literally looks like an ICU room. Her care is like ICU level care. And so these nurses aren't just new nurses you can hire off the street and hope that they can take care of your child without killing them. Okay, next, network adequacy. So 2 areas of this. First is sedation dentistry. It's a service that's needed for many individuals, especially individuals with IDD. But there are very few dentists in the states willing to do this. And it's really not acceptable to ask families to drive 3 hours to get a basic service like dental service. Network adequacy is the responsibility of the MCOs, and this is an area that needs immediate focus, accountability, and some tangible results for families across our state. The other issue about network adequacy is regarding DME providers, specifically those that provide equipment such as wheelchairs, standards, specialized car seats. Currently, there is definitely not network adequacy in this area. One choice, while that might be cost-effective for the MCOs, does not constitute network adequacy, but creates a monopoly, leaving one provider to help all the individuals who require these services. That results for family in no choice, delayed access to essential equipment, and very poor customer service. It shouldn't take 3 to 6 months to get a customized wheelchair or a specialized car seat. A wheelchair, my son, I can go buy him a wheelchair at Munn's if his breaks because he's got the upper body trunk. My daughter, who can't hold her head up and needs all kinds of support to hold her in her wheelchair, I don't have that luxury. And so to wait 3 to 6 months to get her a wheelchair is unacceptable. In addition to like a car seat, like she's outgrown a car seat and waiting this amount of time. It's not just my family, it's others, and I think somebody else testified about how hard it is to get home mods and DME. But this really needs to be something that we look into because, let's face it, it's not a luxury. People need to get to their medical appointments and other things to get, for essential for their health. So families like mine really need help and solutions, and I appreciate this committee's time to listen to our needs and find solutions and accountability for the items that are so critical for the individuals with complex needs to have essential services to promote their health and well-being. Thank you.
Kathy, thank you for your testimony, and just for point of reference, I've been called worse than madam, so thank you. Committee, next we have Matt Johnston, Director of Business Operations of Maxim Healthcare Services. Matt, welcome to the committee.
Thank you very much, Chairman and committee members, for the opportunity to speak today. My name is Matt Johnston. I'm the Director of Business Operations for Maxim Healthcare, a HCBS service provider that's focused on specialized medical care. Specialized medical care provides registered nurses and licensed practical nurses to the severely injured pediatric and adult patients in their homes. These services help the most vulnerable population in our communities thrive while being in the most preferred and most cost-effective setting available, their homes. For over 4 years, myself and a group of specialized medical care advocates have advocated for a significant rate increase for those services from $31.56 to $47. The increase would allow us to recruit, train, and retain nurses. With current funding, only 65% of the authorized services are actually being provided due to the drastically reduced rate that the provider network has to pay nurses compared to other employers. Currently, the budget has been sent to the governor, includes a rate increase to $39 per hour. I want to thank the legislator, KDHE, KDADS, for the focus and the commitment on this issue and the dedication, and we hope for a continued support as we move forward. $39 is a great start and a significant increase, and once again, thank you very much, but still puts the provider network at a significant disadvantage. The rate of $47 per hour was based on analysis of rates from around the country for similar services, and also based on the pay necessary, based on Department of Labor statistics, to attract talented nurses into the field. We are not looking to overpay for nurses. We're simply trying to not ask the nurse to receive 60 to 70 cents on the dollar as they would anywhere else. I also want to say that this is the same rate that we have advocated for the past 4 years, this analysis. Our belief is continued investment in this program will have a massive cost savings for the state by reducing unnecessary hospitalization days and delayed discharges from acute care hospitals. Joint research between the Advocacy Group and KDHE has shown that a 1% decrease in hospitalization from the 528 recipients of this service would create more than enough cost savings to justify the $47 per hour. I've worked for Maxim for a long time. I've seen these families struggle and these patients struggle. The worry and the anguish that they experience when they have stayed up for 3 nights in a row while working all day long because a nurse isn't available to help their loved one. And that is what is needed for these patients, a highly skilled nurse. I've seen life-changing impacts these services can make. And also, we will, even with the 39 increase, we will continue to analyze the data to show the cost savings that comes from that. I want to thank the committee, the legislator, KDHE, and KDADS for continued support in creating a strong program that benefits everyone involved, including the Kansas taxpayers, as these services will make a more efficient and effective healthcare system for Kansas. Thank you, and I'll stand for questions.
Matt, thank you very much for your testimony. Committee, next we have not Sean Balke, but we have some. Go ahead and introduce yourself again.
You're correct, Mr. Chairman. I am not Sean Balke. My name is Amy Campbell. I'm the lobbyist for this coalition of TA waiver service providers. Sean has some work obligations and he's not able to join us today. You do have his testimony and I highly recommend that you look at that. Sean's service, the Craig Home Care Company, provides the TA waiver specialized medical care services in rural areas in addition to Wichita and South Central Kansas. And his testimony is important because what he can share with you is that for folks in the more rural areas of Kansas, the coverage is more like 54% or less. Now, that means that families who have been approved for these services, only 54% or less are able to actually receive them because of the inability to staff for the services. Who are these families? Many of them are families with newborns who are living in a hospital in Denver, and the family is having to travel, stay in hotels to be near their loved one. So sometimes these delays can last as long as a few weeks or even a few months. So as you can imagine, it's a very serious issue, especially as families are trying to work and continue to make a living. I think that you've heard good testimony on this issue. I'll let you read his testimony. Just a little bit of background. We were very fortunate to receive approval for a rate increase by the Budget Conference Committee. The Senate entered at a $37 rate. The House entered supporting a $47 rate, and they ended up at $39. I'm apparently not a very good lobbyist, but you know, it's a good start. And these providers are committed to tracking the data to see how much improvement they can provide. But do remember that their costs of delivering the services have increased exponentially because of PPE and other requirements. So it's not going to result in an immediate boost to nurses' salaries directly. And that's why this rate is very important. We are asking that the House and Senate continue to look at this through omnibus. I understand that there are a lot of competing interests, but we will keep coming back until we can reach a market rate for these services. Thank you very much, Mr. Chairman.
Amy, thank you very much for filling in and for your testimony. Committee, next we have Ann Martin, Director of Operations for Thrive Skilled Pediatric Care. Ann, welcome to the committee.
Thank you. Can you hear me?
We can, thank you.
Okay, thank you. Thank you, Mr. Chairman, members of the Joint Committee for taking the time. My name is Ann Martin. I'm a registered nurse. I also have a master's degree in nursing, and I work with Thrive Skilled Pediatric Care in Kansas. I've been honored to serve the medically fragile pediatric population for more than 20 years. I'd like to present you with these 4 thoughts. As a clinician, I want to be sure you know that our medically fragile pediatric population needs specialized nursing care to keep them at home where they belong, with their families. As a clinician, I want to be sure you know that while there are nurses with a strong passion for caring for these types of children, they also have to pay rent, student loans, car loans, child care, and other costs associated with daily living. The hourly rate paid by the waiver doesn't allow them to follow that passion. Hospitals and other facilities pay much more for their care and can offer better benefits such as tuition reimbursement. The nurses we speak with simply can't afford to work with our special needs kids even though they want to. It's a matter of personal economics. As a clinician, I want you to know that our home health pediatric nurses are providing the exact same high-level care these children receive in a hospital ICU. Many have ventilators, feeding pumps, oxygen, etc. ICU level care at home costs much less than the cost of hospitalization, even if home health rates are increased to the requested $47 per hour. Finally, as a clinician, I want you to know that in Kansas, there are at least 20 families who've been referred to our agency. They are waiting for their baby or child to come home from the hospital, but there aren't enough nurses to provide safe staffing due to the low reimbursement rate. Thank you very much, committee, for helping these kids come home to their families by supporting our rate increase request. I know that there are a lot of needs, and we appreciate your time and attention. Thank you.
And thank you very much for your testimony. Committee, our last conferee is Linda Mowbray. She's the President and Chief Executive Officer for the Kansas Healthcare Association and Kansas Center for Assisted Living. Linda, welcome to the committee.
Hello, and thank you for having me here today. I am Linda Mowbray, President and CEO of Kansas Healthcare Association, Kansas Center for Assisted Living. Our members are long-term care providers, skilled nursing, assisted living, home plus, and FMH. We provide the continuum of care across the state of Kansas. Today, I'd like to start by saying a big thank you to all of the legislators who have been so supportive of long-term care. This last year, had a lot of rocks thrown at us by the public, by the media, that our nursing homes were not adequate, and you all had the insight and the foresight and the ability to understand that our members were doing the best they could with the science they had, with the PPE that they had, with the shortages of staffing that they had, and that the folks that are working in those facilities, caring for the residents who live in those facilities, are passionate about the work that they do and the support that you all have shown us with House Bill 2007, the budget, 2126 liability, and 2114 the senior care task force. All of those things will help us move forward to have a stronger base for our seniors to have care in Kansas. I'd like to draw your attention to one of the attachments to my testimony, and that is a map that shows the country and the outbreak clusters and status at the end of December. The numbers are high. The second attachment shows the outbreak numbers at the end of March. At that time, the numbers in nursing homes were so much better. And the reason? Vaccination. We thank you so much for helping to facilitate and encouraging KDHE and KDADS to work together to continue strengthening that federal pharmacy program as well as the local pharmacy programs to keep our residents and staff in the loop for vaccination. Some of you may have seen a headline out of Wichita today or yesterday, about some outbreaks in nursing homes, that an unvaccinated staff member tested positive and that 5 residents tested positive who had been vaccinated. The vaccine works. Those residents that did contract the disease are asymptomatic, thank goodness. In Kansas, we don't tell people what they have to do. We will not tell people you must be vaccinated. Instead, we lead by example and encouragement. Having the vaccine available, showing that it's safe, and showing that we are willing to participate is key. I get my second vaccine this afternoon. I'm very pleased with that. I would encourage all of us as we go forward to encourage others and to work together. KABC, the Ombudsman's Office, CASE, Leading Age Kansas, KDHE, and KDADS have been great partners. We can do great things when we work together, and I will stand for questions when you have the time.
Linda, thank you very much for your testimony. Committee, that does conclude our conferees for the first part. We will now open up for questions. Do we have any questions for any of the conferees?
Senator Hildebrand.
Yes, Representative Landwehr.
Thank you. I think, one of the things that we've heard now, it's not the first year, second year, or the third year, and that's the issue of the in-home care versus the hospitalization that we're dealing with. And I'm not sure that we have ever gotten, and I believe that one of the individuals that testified had somewhat of a breakdown of what it costs in hospitalization versus if we were providing the in-home care at that possibly $47 or $48 rate. So maybe staff can get us a better look at that, and it might be something that Chairman Carpenter has more information on because he does deal with the social services budget. But I think that we're not improving this at all. I mean, the $39 is nice, but it's still not going to get us where we need to be. And we're spending a lot more money in hospitalization than if we actually just provided the $48 and provided the care. So that's either a staff or perhaps only Chairman Carpenter question on what we can get.
Marisa, would that be something for you or that we could get? Okay, thank you. Representative Carpenter.
Thank you, Mr. Chairman. Thank you, Representative, for that. I'm not sure now what the fiscal note is between the $39 and the $47. So that would be something that the staff could find out the difference. I've slept a couple times since the budget, so I don't remember exactly what the figures were, but that would be nice to know. Again, I've been an advocate of this for a number of years because it saves money and it improves care. So thank you for the questions, and we will more than likely be talking about this during Omnibus next Tuesday. So thank you.
Committee, do we have any further questions or comments? Representative Concanon.
Thank you, Mr. Chair. Sean Gatewood. So I'll start asking while you're walking up. In your testimony, you bulleted some chronic and immediate needs. And I'm wondering on the juvenile mobile crisis response, is this something that, why don't you explain that, what that is? Do we already have that and we need it expanded, or is that something you'd like to add to state services? And what's do you know the cost?
I do not know the cost. That is something that would be particularly valuable with being able to get out to sort of rural areas. Right now, really crisis, it isn't served well, except for in the metros, and even at that, it's fairly limited.
What does it look like, though? I mean, are you talking about a mobile vehicle that travels around the state, or?
I think that yes, potentially, but I think that to get too far into the details of those, we probably need to get some of the more mental health focused and foster care focused, because that's really the system that is impacted the most deeply on that is the kids that are in foster care, crisis, the suicidal kids, and sort of having that deeper understanding of how that works.
Okay.
Would more be them, although we're very supportive of the concept.
Okay, thank you. That's why it caught my eye. Is I thought that would be something that would benefit foster children. So.
Yes, ma'am.
Thank you, Mr. Chair.
Representative Ballard.
Thank you, Mr. Chairman. I just have a comment, and then I have a question for another person for, let's see where she is, Kathy Keck. I think you were the one that mentioned that we really need to pay more attention to home mods. Am I correct? That is an important issue, and for the first time from my constituents this year, I've received a lot of questions about home mods, and I think maybe because people were at home more and they had so much to do, that might have triggered that, but that's an area I think we should look at. My other question is for, well, not a question, but my question now is for Rachel Munger. I was taking some notes, and I'm hoping I'm accurate, but I think you were saying that for the first time you've seen a shortage in housekeeping and dietary shortages. What have you been doing about that? Because if that continues, that creates another problem for you in addition to direct care, but this is another area that we may not think is that relevant, but it is, because you also have to have clean facilities and everything else. Go ahead.
Yeah, so I think when our providers were initially looking at hazard pay and incentives and things like that for the pandemic, it was really focused on nurses and nurse aides, and that's really for everyone in that building. So we have been working on trying to attract people in with the wages that we're able to do with the emergency funding. As I mentioned in my testimony, we've had to go to temp agencies. Some of our members, we had a virtual lobby day yesterday with some of our congressional delegation, and some of our members were expressing some frustration about some of those dietary and housekeeping positions, they feel like with the extended unemployment bonuses has really hurt them in trying to get people to come in and take some of those jobs. So we're hoping as some of these crises pass that we'll be able to recover some more on that front. But until then, it's offering more incentives and going more into the community to make sure people know that these jobs are available. Because a lot of times people think of a nursing home, they think of the medical side and not so much all the job opportunities that there are outside of that.
Mr. Chairman, may I follow up?
Definitely.
What did you have an adequate staff before COVID?
We had issues before COVID. Even within housekeeping and dietary, we'd hear that, we're always advertising. It is another higher turnover area, but not to the extent that we have it now as we've gone through the pandemic. I have never heard of a member who's had to do temps agencies for those types of positions that aren't even specialized. They're just, they're important, but you know what I mean? They don't require a certification or anything like that. They're just normal types of jobs. We've never had to turn to staffing agencies for those types of things before.
And for the individuals who departed, was it COVID related or they just left, or like for what reasons were they not there?
I'm not sure because I'm not running the buildings, but I'm sure COVID had a lot to do with it. Even just fear of COVID, but also all of the stress and trauma that came with just working in those environments and getting through that. And they're just high turnover positions anyway.
Okay.
So.
Thank you. Thank you, Mr. Chairman.
Representative Landwehr, then Representative Lind.
Thank you, Mr. Chairman. This would go back to the question that was asked earlier on the mobile crisis program. And actually, if you were to Representative Concanon look at House Bill 2281, which is the 988 legislation, one of the pieces of that, which is when we're asking for a fee on phone lines, is to help pay for mobile crisis systems. And these would be for the behavioral health side as well as the IDD side. And it would be kind of like a volunteer fire department where you had these individuals that had their jobs currently at CDDOs and at CMHCs, or soon to be CCBHCs. And when a mobile crisis team needs to be dispatched, then they are paged and then they move. And I believe, and this might be something that I think maybe Andy Brown or someone from KDADS is talking later today, that the idea is for the rural community, because obviously that's easier in our urban communities, is to be no further than, I want to say, like 30 minutes to an hour away from any individuals in order for those crisis teams to go out. So I hope that that's helpful.
Representative Lind.
Thank you, Mr. Chair. I have a question for Sean Gatewood. It's just more of a general question. I was wondering if you could tell me a little bit more about the autism waiver with the 400 kids on the wait list. You said that many children under the age of 6 aren't being served. Can you tell me the approximate age when kids are typically diagnosed with autism? And is this having to do with their age or the lack of providers?
It's very much a lack of providers. There's just not really as much of a network. I would probably refer the question about the average age to Interhab. They work much more closely with folks with any kind of an IDD issue. But yes, it's very much about the provider network.
Okay, thank you, Mr. Chair.
Committee, okay, we have one more question. Representative Concanon.
Thank you, Mr. Chair. My question's for Kathy Keck. You talked about the sedation dentistry, and I kind of was reading through your testimony, and you were asking for, I'm just kind of wondering what we can do about it. You're asking for immediate focus, What do we need to focus on? Accountability, is that accountability to the MCOs, and then tangible results? And I'm just kind of wondering how we would look at those.
I think it's absolutely has to do with network adequacy for the MCOs finding appropriate providers, paying appropriate providers. There could also be some, I have one of my children has Blue Cross Blue Shield and Medicaid and can be seen by a provider as close as Kansas City. However, another one of my children, because he has Medicare and Medicaid, cannot be seen outside of a hospital setting because of Medicare rules. And so it has to do definitely with network adequacy because there's not enough providers who are willing. I'm sure it's costly when you talk about sedation and the risk involved of sedating somebody for dental work. I'm sure there's risk involved, but I think that there's no providers or not a lot of providers willing to do that. So I think it's with the MCOs and trying to find some providers to be able to help families and do that. I know, like for us, even I live just south of Topeka, and we have to drive about an hour, but I know a friend of mine that lives in western Kansas and drives 3-4 hours to figure out where to take their child to get teeth pulled or just simple things that, teeth cleaning in our case. So, yeah.
Okay, so yeah, I was just kind of wondering how we could help. So it would be for us to follow up with MCOs. Okay. Yes. Thank you. Thank you, Mr. Chair.
Committee, seeing no further questions, we would like to draw your attention to written-only testimony from KanCare Meaningful Measures Collaborative. And next up on our schedule, we have a presentation by our KanCare Ombudsman, Carrie Bacon. Welcome to the committee.
Thank you. Can you hear me?
We can, yes.
Okay. My name is Carrie Bacon. I'm the KanCare Ombudsman. Chairman Hildebrand and committee members, I appreciate being able to speak to you today. You have a copy of the report and my written testimony. I would really like to focus on just a couple of things today. Well, first I wanted to double check and make sure that you had received the annual report. It should have come out, I think, in March.
Carrie, yes, we did. Thank you very much.
All right. So for first quarter, our levels for initial contacts is remaining about the same for the pandemic. It's definitely lower than what was normal pre-pandemic, but it's remaining about the same. I will note that our response time for getting back with people improved during first quarter. And I would say that that's probably due to the fact that we hired a volunteer coordinator, and she is covering the Kansas City office when we don't have our 2 volunteers there. So it has made a difference in leveling out who's covering what calls and being able to get back to people in a more timely fashion. The one thing I really wanted to focus on today is a new resource that is available, and we're calling it the Community Resources by County. And I wanted to make sure that your group understands that most of this work was not done by staff. Most of this work was done by interns that we have partnered with the University of St. Mary's and their health information management intern program. And they have been partnering with us for several years to make this program happen. And we now have enough resources by county that we've put it on our web pages. And if it's all right with you, I would like to share a screen so that you can see that.
Yes, please.
Okay. Okay, so this is, I'm sorry, I'm on the wrong page. This is our resource page. If you go to just the Ombudsman landing page On the side are the quick links, and right here is our community resources by county. So this is the page now, and there's a picture of it in the report, but I think it's helpful to see it on the actual website. So you can see most of this is in blue. There are some that are still black. That means they don't have links yet. And that is because the last 2 interns are currently working on this to get all of these up to all of them completed. This should be completed by May. The piece that I guess I want to make sure you understand about this is, well, let me just pull one up here. Franklin County. I used to live in Franklin County when I was a kid. I had someone, the reason this started, this project, was because I had a member call me and they were struggling with several things, but one of them was food insecurity. They were having to make choices between some of their medical needs and rent, utilities, and food. And I went out online, made some phone calls, and came back with a list. And she really was not a believer. She thought she knew all of the resources that were available in her town. And when I went through the list, there were about half of them she did not know about. And so it made me realize, and then we get calls about people who are struggling to catch up on utilities or they're homeless. And the things that we have included here is not comprehensive, but what we're targeting are the basic needs that people have when they're on KanCare. They are that level of income that these are the kinds of things they struggle with. So it's basically medical. It is, go on down, we have local resources and regional resources that people are a lot of times not aware of. And then food, transportation, and shelter has several subheadings. And then we list other resources. KDHE has a resource toolkit, and the Kansas Commission on Disability Concerns has additional life resources and resources for youth that we've included. And depending on the county, we may put additional things under there if there is their own, if they have their own community resource section, that kind of thing. But I feel pretty strongly about this resource because we do get these kinds of calls that they're struggling with figuring out where to go for resources just to maintain. And I think we forget sometimes that if you're on Medicaid, the limit is $495 income to be eligible. And the next limit is, if you're over that limit, you may be eligible, but it's with a deductible or a spend down. And so you have to be able to pay your medical bills and live on $495. That's basically how it works, because deductibles are just for medical bills. It's not for other living expenses. So in my mind, this is definitely related to Medicaid. I hope you understand how I'm making that connection. So we have this done almost for the entire state. And we are going to continue our partnership with University of St. Mary's, and they will begin updating. This was started long enough ago that we think some of those services may not be there. There may be additional services. And quite honestly, when you have different people trying to accomplish the same thing, you don't always get the same consistency. And as we've gone through 2 or 3 years of this, we have added some things and not gone back to the beginning. So I've set up the process for updating so that it should make it more consistent across the different ones. But we're not going to wait until we have everything perfect. This is good information, and even if it's not 100% correct, it is still going to be helpful to people that are in need. Our next step in this project will be using the interns from University of St. Mary's not only to update, but to have make connections then with community-based partners in that county to say, would you put this on your website? Would you print these off and give them to people who come into your office so that they have access to these resources? And so again, we will be partnering with University of St. Mary's, the Health Information Management, and also we may be partnering with the social work program to do this next phase. Those are the main things I wanted to bring to your attention. If you've got any questions, I'd be happy to talk with you about them.
Let me push the right button there. Carrie, thank you very much for that. We do have a question from Representative Carpenter. And
Carrie, Representative Carpenter here. I wanted to thank you for this. I have been looking for something like this for a long time. We've tried various deals, and I think that's great. I think that you need to send this out to every legislator so that when they do have inquiries into these issues that, you know, I would think that I might know those folks, but I see some folks on here that I'm not aware of, which is very helpful. The only thing that I might add here is also send that out to the schools. I think the schools are front line in dealing with these folks that have food insecurity or a lot of mental health issues and things like that. And somehow if we could partner with them, that would also be good. But great job, and thank you for this, and continue your hard work on this. Thank you.
Thank you.
committee, do we have any other questions for Carrie? Representative Lynn.
Thank you, Mr. Chair. And I just want to second Representative Carpenter's. I think this is incredible. And I wish I had known about it at the beginning of the pandemic, because I know we've had a lot of constituent needs that can be served with this list. So I just want to say thank you.
Thank you for your comments.
Okay, not seeing any further questions. Committee, we will now move our attention to the presentation from the Office of our Medicaid Inspector General, Stephen Anderson. He is our Medicaid Inspector General, and he is, I believe, correct me if I'm wrong, this is your first time appearing before our committee.
Yes, sir, it is.
Stephen, welcome to our committee.
Thank you, Chairman Hildebrand, members of the committee. Thank you for the opportunity to appear today and discuss the Office of Medicaid Inspector General with you this morning. My name is Steve Anderson, and I was confirmed by the Senate to serve as the IG on April the 6th, much awaited. And I am pleased to be here today to provide this update. I understand you have a prior copy of it, so I'm going to go through and hit the highlights, if that's okay, sir. Staffing, following my confirmation, the office is back to its full staff of 3. We hope to eventually recruit more staff as appropriations allow. Right now, that's not really in the cards. So who am I? For those of you who don't know me, I am a 30-year law enforcement veteran, primarily with federal and past 5 years with the Attorney General's Office and Medicaid Fraud and Abuse Division as their special agent in charge. Prior to that, I had a long career with the federal government doing program fraud investigations. Our other staff is Lori Knutson. She's an assistant Medicaid Inspector General. She's a trained auditor. She's working on getting her certified fraud examiner license. And then Josh Saitoff, he's a data analyst. He's been with us for about a year. And prior to that, he was with Cerner Corporation. He is a very talented young man. We're very fortunate to have him. Our annual report was released for 2020 on February the 17th of this year. The report provides an overview of our activities, explains the fraud report complaint processes and related stats, and outlines the oversight activities that took place from January the 1st through December 31st, 2020. In calendar year 2020, the OIG screened a total of approximately 650 fraud reports for substance and jurisdiction. Out of those 650 reports, 629 or 97% were submitted by the Kansas Department of Children and Families, which is a big percentage of them. And just by comparison, in 2019, the IG's office screened a total of 227 fraud reports, which were primarily submitted again by DCF. And that's a 186% increase over 1 year as far as the number of referrals we're getting from them. I think part of that is just because they know we exist now. Below us, there's a list from the committee meetings, the reports that were issued. We did an analysis of transportation grievances, HHS OIG exclusion list, overlapping of PCA and inpatient claims, follow-up review of the APRIS system, and then capitation payments made as after beneficiaries' dates of death. The one I'd like to point to is the capitation payments made after beneficiaries' deaths. This review was to determine if KDHE made capitation payments to MCOs on behalf of deceased beneficiaries between February 2015 and September 2020. My office identified $1.3 million in monthly capitation payments that were made on behalf of 25 beneficiaries whose dates of death preceded the payment dates. In some cases, improper payments continued for as long as 5 years after date of death. The complaint process and report of investigations, the IG continues to oversee complaints of fraud, waste, abuse, and legal acts concerning the KanCare, Medicaid, and CHIP. Since the last meeting of this committee, our office has received 164 complaints. Again, the majority of them are from DCF, all but 7 of them were. COVID-19 monitoring. To date, we continue to look at everything, but to date we have found no evidence that practices involving COVID-19 fraud have been significant or have been found, but we are continuing to watch that and monitor it. That is something our analyst does on a regular basis. The upcoming report that we hope to definitely have published before the next quarterly meeting of this committee is the Medicaid review. We've been conducting preliminary results of that. Medicaid is a 100% funded, state-funded program, and there's no federal funds involved in it. There appear to be indications that perhaps there were people that were on there past the 12-month limit, and we're looking to see why that occurred and if there was a process failure. With that, thank you for your time, and I would be more than happy to answer any questions or take suggestions from the committee.
Stephen, thank you very much for your update on your office. The capitation issue that your office had discovered, do you guys know how that happened and what steps have been taken to ensure that it doesn't happen again?
We know partially what happened. We know that the key system that was created in 2018 failed to pick up the people who had died in 2015, 2016, 2017. We're not sure exactly what happened. I will tell you that we are continuing to look at that problem. And since this report came out, we've found additional individuals who died, and there was continued capitation payments for them following that. So we intend to dig in it much deeper and get a better understanding of what happened. And we will plan to report back to this committee with our findings.
Stephen, I appreciate that. It sounds like we have some questions for KDADS when they come up. So thank you very much. Committee, do we have any other questions for Stephen? Okay, not seeing any. Oh, we do have one. Representative Landwehr, do you have a question?
Yeah, thank you, Mr. Chairman. Going back to the Medicaid, wasn't that previously at 24 months and now we're saying it's 12?
Thank you, Representative Landwehr. My understanding is it's a 12-month program. There are people who are released from mental health facilities that are given a basically a non-ending result for that or opportunity, but the current program as it stands right now is strictly a 12-month time limit.
I guess, Mr. Chairman, I'd like to have staff go back and look. It seems like to me at one time, and Representative Ballard may actually be able to answer that, that perhaps this was a 2-year program and that it was put into place because of the approximate 2-year delay that it took for SSI, unless I'm confusing my programs.
Well, the program was certainly for SSI, and people that had applied and had that gap that occurred. We would be happy to research that as well and report back on it in our report on the Medicaid. Again, we hope to have that report prepared for this committee by next quarter, by next meeting.
Thank you.
Representative Ballard.
Thank you, Madam Chair. Boy, you got it twice today. Thank you, Mr. Chairman. I was about to say, Madam Chair, but with Representative Landwehr, I believe it was a 2-year program, and then it was shortened, but am I positive? No, but it does stay in my mind that it was 2 years at one point. So thank you, Mr. Chair.
Committee, seeing no further questions. Stephen, thank you again for your update, and we look forward to seeing your reports.
Thank you. Thank you, committee.
Committee, next we will turn our attention to responses from our state agencies on unresolved issues. And first, we have Sarah Furtick, the Medicaid Director for KDHE. Sarah, welcome to the committee.
Thank you, Mr. Chairman. Good morning, committee. So I will go through KDHE's responses on the log. The first item that we are going to respond to is item number 2, which is on page 3 on my copy. Let's see. So this particular concern was expressed over the course of 2019 regarding the Kansas Hospital Association's survey indicating that there were some providers that still had some accounts receivable from Amerigroup. We don't really have any further update on this. We followed up on this in December of 2020, and at that point, those amounts had dwindled quite a bit, and they continued to dwindle in the following months. Mr. Chairman, I would suggest that perhaps we could strike this item. At this point, we are far past the window for providers to submit claims to Amerigroup, and we're also outside the window for any appeals for that. So at this point, there isn't really much else that can be done on this particular item. The next item.
Oh. Sarah, I'm sorry. Did you want us to strike that, or I was just going to see if there are any objections from the committee. If there are none, we'll just go ahead and ask that that be stricken. Representative Carpenter.
As one of the people that continue to kick this horse down the road, I'm certainly able to strike that.
Seeing no objections, we'll get that stricken from the list. Representative KanCare.
Thank you. I just have a question. Do we have this spreadsheet? Oh, email. Okay. All right. I'm on the website. Thank you. Thanks, Mr. Chair.
Welcome. Sarah, thank you. You can go ahead and continue.
Thank you, Mr. Chairman. The next item we were going to address is number 14. And this is kind of a combination item concerning some workforce issues and reimbursement rates. The item in particular that we are going to address relates to the private duty nursing reimbursement rate. We heard some more testimony this morning about that. Private duty nursing is also known as specialized medical care, also referred to under the T1000 rate. And this is particularly important to the TA waiver kiddos. I would note that House Bill 2007 does include 1.5 million all funds to increase the rate from $31.55 an hour to $39. I believe that bill is awaiting the governor's action. So at this point, there has been some legislative response to that. The next item that we would discuss is, let's see, item number 15 on the same page. And Mr. Chairman, this is another item that we might respectfully ask to be stricken from the log. This was a request related to action to be taken during the 2020 legislative session concerning the provider tax, and we're not in the 2020 session anymore. So we don't have any further update here, obviously, and we might suggest that this item be stricken as well.
Sarah, we'll see if there are any objections. If there are no objections, we'll strike that from the log. Okay.
Mr. Chairman.
Representative Landwehr.
Thank you. So we have continued the provider tax. Is that what you're telling us, Sarah?
Yes, that's my understanding.
Okay, so that's why we're willing to strike it at this time, because it's continued through how long?
That I don't know, Representative Landwehr. KDADS would probably know that.
All right, thank you.
Mm-hmm. The next item we were going to address is item number 23, which is a couple page further. This particular item also concerns the specialized medical care / T1000 / private duty nursing rate. And our response to this item is the same as our response that we had for item number 14. I would suggest, just for ease of following this particular item, we might consolidate all conferee concerns related to this particular rate into one item. But that's up to the committee.
Sarah, I think that's an excellent idea and suggestion. And if there are no objections from the committee, we will combine those. Seeing none, we'll do that. Thank you, Sarah.
Thank you, Mr. Chairman. The next item we were going to address is item number 28. And this concerned the special session House Bill 2016 and the fact that it did not include liability protections for nursing homes. Mr. Chairman, I would suggest that perhaps we strike this one. It was assigned to KDHE, but there is nothing we can do to insert liability protections for nursing facilities. That is something that would require legislative action. So I would respectfully suggest that we go ahead and strike that one.
Sarah, I agree, because we did recently just pass that legislation.
Mm-hmm.
So without objections, we will have that stricken from the log as well. And seeing none, we'll strike it.
Thank you, Mr. Chair. Moving along, the next item we were going to address item number 30. So item number 30, we received some concerns from some of the advocates about COVID data reporting. And if you note that these concerns were presented in June of 2020. Since that time, KDHE has launched a coronavirus website that does include cluster reporting, so that individuals have a more recent idea of where outbreaks have occurred. We also offer county level reporting on that website. So I think a lot of the concerns that these particular conferees had in June of 2020 have been addressed. So we don't really have any update on this, Mr. Chair, but this is another one that we might suggest striking, as our KDHE's coronavirus site now includes a lot of the data that these conferees were seeking. And we're essentially reporting that data as specifically as we can while remaining compliant with HIPAA. We could always certainly reopen a new item if there are new concerns that the conferees have, but we think we're almost a year down the road and we think these concerns have been addressed.
Committee, do we have any concerns on this one? Okay, not seeing any. We will strike that from the log as well.
Thank you, Mr. Chair. The next item we would address is item number 39. And this particular item includes a number of concerns related to long-term care facilities. KDHE's response is going to be specific kind of to the second paragraph on this item that relates to vaccines. The concern that was expressed was whether healthcare workers and nursing home residents would continue to be prioritized in terms of the vaccination process. Right now, Kansas is in phase 5 of the vaccine rollout, which includes all persons who are age 16 and up. and all unvaccinated persons from prior phases. So really, at this point, anyone 16 and older who wishes to receive a vaccine is eligible for one. So we can certainly keep this on, Mr. Chair, if the committee wishes to keep an eye on this, but we kind of think that at this point, since we are in phase 5 with the vaccines, it's almost kind of moot, this particular concern.
Committee, do we have any concerns about striking this from the log? Okay. Not seeing any, we'll strike this one from the log as well. Thank you, Sarah.
Thank you, Mr. Chair. The next item we were going to address is item number 40. This was an concern expressed by a couple of conferees. They were concerned that once the CVS and Walgreens program expired, they wanted to make sure that adult care homes and staff would continue to receive priority for vaccine access. Our public health division informs me that the way it works currently is that the nursing facilities work with their local health departments and pharmacies to obtain vaccines. Our understanding is that there haven't been any recent problems regarding access to vaccines by nursing home facilities and staff. And also, I would just reiterate that we are in phase 5 for vaccines, so any interested person 16 and up who wishes to receive a vaccine is eligible for one. The next item we were going to address, and I believe this is our last one, is item number 45, which should be on the last page. This was a concern that Linda Mowbray expressed, basically indicating that, you know, with some of our HCBS members, frail elderly or what have you, there's some uncompensated care due to the gap in eligibility between when the application is filed and when eligibility is finally established. And I would indicate that CMS rules do not allow us to establish HCBS eligibility until 3 items are in place. One of them, the individual has to have gone through their functional eligibility assessment and be determined to be functionally eligible for the waiver. The second item is they have to be determined financially eligible for Medicaid. And then the third is that a plan of care has to be in place. So we realize that this is an issue that providers are struggling with. And so the state has taken some actions to try and expedite this process. Specifically on the application side, we prioritize HCBS applications above other ones to make sure those go through the process quicker. And we've also allowed a provisional plan of care to be put in place so that HCBS eligibility can be established quicker while a more long-term plan of care is worked out with the MCO. And Mr. Chair, that concludes my report out on the issues log, but I would be happy to answer any questions that the committee may have.
Sarah, thank you for that. And committee, we will open up for questions. Representative Carpenter.
I just have a quick question. My sheet only goes to page 29. Is there another sheet here that? The updated one. Okay. Sorry about that. And then one of my questions would be, what provider tax were we talking about? The nursing home provider tax?
That was the nursing home provider tax, Representative Carpenter.
Okay. All right. That's what I thought, but I was unsure. Thank you.
Mm-hmm.
Okay, committee, not seeing any no further questions. Sarah, thank you very much for that update. We will now move to Janice DeBeer, the Deputy Secretary of Programs for KDADS. Janice, welcome to our committee.
Thank you, Mr. Chairman and members of the committee. I'm glad to be here. Janice DeBeer, Deputy Secretary of Programs at KDADS, and we are going to start with number 1, Marissa. Thank you very much. I do think it's important to say once again how much we appreciate Marissa's support in managing this log sheet for us. She has just done a superb job, so thank you, Marissa. On number 1, we are pleased to echo what you've heard already this morning from several conferees regarding the IDD waiting list. It is our plan, and we appreciate your support, to bring some folks together this spring and summer and talk about the waiting list and what we might do to gain a better understanding of how to address it specific to Kansas. So we appreciate that. You will see throughout this log sheet that there are, I think, a couple of references to the waiting list. So just to repeat myself if I need to throughout this presentation, it is our intent to pull together a group of stakeholders and other experts to help us talk through the IDD waiting list. The next issue is number 4 for us. Excuse me. This is actually from Cindy Luxem, so it's fairly old as far as the issue, but it's regarding nursing facility funding, and we just wanted to note that you all did include funding for nursing facilities for fiscal year 2021 in the appropriation bill, and then you also included a 3% increase for 2022. Looks like we might have a question from Representative Landwehr.
Representative Landwehr.
Thank you, Mr. Chairman. So then did we do the 3-year rebasing? You talked about an appropriation. So has the 3-year rebasing been corrected now?
So that the costs are still being reviewed with the stakeholders, but it's my understanding we do have consensus from the stakeholders that the 3 years they are wanting us to use are 17, 18, and 19. Yes, Representative Landwehr, for the upcoming rate setting year, which then coincides with the 3% increase in funding.
So maybe, Mr. Chairman, what we need to do is that we just need to update this item with what we were just told on this, and then monitor until we see that it is at completion for the rebasing, because this has been an issue ongoing since I returned in 2017.
And Representative, one reason we didn't include more detail in our particular response at this particular point in time is because decisions haven't been made, final decisions haven't been made yet. We're still working with stakeholders.
Right, thank you.
Janice, we have a question for you from Representative Carpenter.
Okay.
Thank you, Mr. Chair. Janice, is there any way we can change, now this was rebased, and statutorily it's required to be rebased on current costs for the last 3 years. When we were doing this in appropriations, the study that has those costs does not come out until after we're already out of session and the budget's already done. Is there any way to change the dates on that rebasing study so that we would have accurate numbers?
Representative Carpenter, I would share with you, and no, as far as how the cost reporting timelines work. So the nursing facility cost reports are based on a calendar year from January through December. And the nursing facilities are asked to submit their cost reports by February 28th. I believe years ago, Representative, the nursing facilities industry was given, it was maybe 3 months. And then we asked them to collapse that to 2 months. So we actually asked nursing facilities to get their entire calendar year cost report completed in 2 months, which is really accelerating, I think, response to our cost report application. Now, there are experts out there. There are CPAs who work with nursing facilities every day and comply with the February 28th date, but it's asking a lot, I think, to ask nursing facilities to have their cost reports to us within 2 months. And then we need a month and a half or a month or so to review those costs and ask questions. We have auditors who respond to those costs. That takes us at least a month, if not 2. So then we're already January, February, March, we're already at April. So that's the point we're at now. Our contractor and our auditors are reviewing the cost report information, and then decisions are made for the July 1 rate setting. And then Representative Carpenter, once those rates, the decisions are made, the rates become final, then, we have to give those rates to KDHE so they can get all the changes made to the rate. So it's quite an accelerated process from December 31st to July 1, to say the least. I don't know how we could speed it up.
Okay, so you use 17, 18, and 19?
Correct. That's the consensus thus far as to, and Representative Carpenter, it won't surprise you, 2020 is going to be an anomaly year, we believe, at least at this point in time. I mean, 2020 costs that captured COVID costs are going to be quite unique from our experience in the last, 40 years of doing this. They're going to be unprecedented.
I get that. Thank you.
Janice, thank you. You may proceed.
Okay, let's see. Our next response was number 7. Based on your feedback from the last couple of Bethel meetings, we are going to go ahead and pull a work group, or we're going to bring in some stakeholders. Hopefully we can get a group together this spring and summer and ask Roxanne to join us, obviously, to talk through what this particular issue might look like as far as impacting the SED kids and the IDD waiting list individuals. So we're going to go ahead and bring Roxanne to the table with some other stakeholders and just talk this through. We should have already probably done that because this issue's been on the log sheet for a while now, but we will go ahead and get that done this spring or summer and see if we can hear some additional perspectives and report back to you. Okay, our number 8. This is from Nick Wood, where he is talking about behavioral health services for folks with IDD. You're going to hear me repeat this a couple of times also. We are going to talk about the 988 opportunity and mobile crisis. Representative Landwehr, you mentioned earlier that you responded earlier about the mobile crisis system. Our Secretary Laura Howard has indicated she will give a brief overview of what's going on with the mobile crisis system that's being developed now for children and youth. And then again, Andy will talk about it, Andy Brown, this afternoon. He will talk about the Mobile Crisis Center. The good news of developing this type of system, as Representative Landwehr mentioned, with the 988 and the mobile crisis systems for children and youth and adults with mental health issues, there's no reason at all that we can't work closely with the IDD community to also make this work for individuals across the state in general. So that's the good news. I think Representative Landwehr has a question.
Representative Landwehr.
Thank you, Mr. Chairman. It's more of a comment, is the problem that we're up against, and you'll probably hear that later on this afternoon when you hear from Andy Brown from KDADS, is the stall that we currently have with the 988 legislation because of the telecoms not feeling that a fee should be placed on phone service in order to pay for the services for people that people will require when they call this 988 suicide prevention hotline. This is not an option. This line will go live on July, I want to say it's like the 12th or 16th of 22, whether we like it or not. And if we don't get legislation passed or have, funding mechanisms, and if we can't see movement on a fee, Mr. Chairman, you will see a proposal during the appropriations process next week to come in with probably somewhere around a $10 million plus SGF funding request to be able to provide the services. And then should the legislature choose that it will wait to pass the 988 legislation, at least KDADS would be able to make sure that we have the professionals hired and that they are ready to answer the phones, because this isn't like the 911 system. The 988 system actually requires mental health professionals to answer those calls so that they can hopefully deal with the individual on the phone. If a mobile crisis team is needed, then they can dispatch the mobile crisis team. And then it also provides a lot of follow-up services. But right now, that legislation is in limbo. I believe that most, if not all, legislators received an email in the last couple of weeks from Verizon and T-Mobile expressing their concern that they don't like the 50-cent fee that the legislation is looking at. They want Kansas to wait until they see what other states are doing. I can tell you, we've got one state out there that's asking for $1.50. Kansas is coming in, and we're willing to look at like a 30, starting at maybe 30 cents and go up to the 50. But there's nothing that moves on this mobile crisis stuff or anything else. And Janice can correct me if I'm wrong, unless this 988 legislation passes in order for us to fund those mobile crisis units.
And Representative Landwehr, if I may piggyback onto that, I will share with you, and I hope that members of the committee notice this as we walk through this issues log sheet, that with the 988 and the mobile crisis for the children and the youth, which is already happening at DCF, and then the opportunity for mobile crisis for mental health individuals, adults who are adults, what will happen then is we will then have an opportunity to also address the IDD community. So it feels like this is a true opportunity with the conversations that were had this summer, Representative Landwehr, with your leadership to bring in, a 988 system and a mobile crisis system. And then we've got the kids going, and now we bring in the IDD community. I mean, this is a real opportunity for us to expand crisis services in Kansas that will impact a lot of populations who need that service. So with number 8, what you will see from Nick Wood at Interhab is, hey, what can we do for crisis services for the IDD community? What our responsibility is, in my opinion, at KDADS is we've got to make certain that as we continue to work with you all and the governor's office and DCF, and even within KDADS, that we bring in the IDD community and our stakeholders to make sure the system that we build also addresses the concerns that we've heard from years from IDD providers, both at the state hospitals and community-based providers. So we are doing our best to make sure that we stay connected within the agency. And Laura or Secretary Howard can speak to that more. And I think Amy Penrod and Commissioner Andy Brown will also speak to that this afternoon, that this is a true opportunity for us to address a lot of these issues.
Mr. Chairman, if I might.
Go ahead, Representative.
Janice is absolutely correct. And one of the things is there was a separate bill that Interhab had asked to be introduced to deal with IDD mobile crisis. And it was the decision of the House Health and Human Services Committee to make the mobile crisis part of the IDD legislation to be funded within this 988 funding mechanism so that we can address these individuals. Because what happens many times is people don't realize there is a difference between dealing with our IDD population and our behavioral health population, and it really takes a special skill set. We had, I want to say maybe it was in 20 or 19 when we had Interhab came in and gave us a presentation on some of the horror stories that have actually happened across our state, where individuals, because of the IDD population and their physicality, that sometimes they overwhelm even our law enforcement. And there were a few cases where we were very fortunate that the right IDD person was able to be there to help law enforcement calm this individual down so that they could be taken back for services, versus what law enforcement felt the alternative would have been, is the individual probably would have been shot. So this is not something for us to take lightly. Dealing with this IDD population is a big deal, and having these mobile crisis teams for both our IDD and our mental health is very important. Because I can't imagine, right now we have some of our 911 dispatchers that have sat on lines and heard the gun trigger being pulled or the shot go off, not the trigger necessarily, but the shot go off, because we couldn't get crisis services out to an individual on a timely basis. So this is at a crucial point, and it's been very disappointing to me that the telecom industry, Verizon and T-Mobile, have decided that it's not worthy to put 50 cents onto the phones in order to pay for these services and make sure that they're available, because Kansas has not kept up a robust mental health system in Kansas. And I know that there's a lot of legislators too that are having angst over, you know, a 50-cent tax or fee, as you want to put it. But I don't know that, you know, 50 cents is, you know, I looked at my bill. I'm probably going to pay, because of the phone lines we have, about $5 more a month, but I think that's probably worth it versus coming in and having to fund this through an SGF level, which we wouldn't be able to do, because this 988 line will have probably about a 200% uptick on phone calls and situations in which they have to be able to address the IDD and the mental health population that we have out there. So I think it's just kind of a sad state of affairs to see the telecom community and some legislators think that it's not worthy to take care of these individuals.
Okay, number 9 is our next item. And I will just simply say, in response to this issue, we are still very interested in bringing in some experts to help us identify the gaps, but it makes sense for us to do that, you know, on the heels of COVID, where we were a bit distracted, but it makes sense for us to do that now after the legislative session to see what happens with 988 and even get a better sense in Kansas, regardless of 988, how the mobile crisis systems might work that are going to be funded. So we are still very interested in working with Nick and Matt at Interhab and others and their community-based members to talk about where are the gaps in system when it comes to those individuals who truly may find themselves incarcerated as a result of having a dual diagnosis. And that feeds nicely into number 10, issue number 10, which is very similar, also from Nick, about the community-based systems and those individuals who may find themselves incarcerated at one of the state hospitals, and how do we get a better handle in Kansas on how to address those. And we feel the best starting point is to make sure we understand the gaps in the system and what we've got to look forward to. Again, I will echo Representative Landwehr's comments. A mobile crisis system is certainly going to help us, and that is coming for the kids and the adults with mental health issues. We certainly feel that there needs to be an opportunity to also provide similar services for the IDD folks, and 988 would certainly help. But enough of that. So on to number 15. From our vantage point, as far as having an update on the provider tax, number 15, Sarah asked that this be removed, and we would echo that. I just texted Connie Hubble, and Connie indicated that our provider tax Representative Carpenter extends for 10 years to July 1, 2030. I think Connie just let me know. So that we appreciate being removed from this issue list also. Number 16, again, this speaks to the IDD waiting list, and Steve Gabar, who brought this issue to the table, will be joining us at the table as we study the needs of individuals on the waiting list. So we appreciate Steve's participation.
Janice?
Yep.
Just a question. Since there are so many issues for KDADS on the waiting list, would it be easier to track if those were combined as well?
Yes.
Instead of having so many separate ones?
Yes,
okay.
Very much.
Without any objections from the committee, we will do that. Thank you, Janice.
Sure. Thank you, Mr. Chairman. Number 17 is our next issue. This was from Sean. Oh, we appreciate this from Sean Gatewood, who indicates that we need additional staffing in-house, and we would actually agree with that, that we could use some additional resources, but we will talk with you all later about that in the governor's office. So From our vantage point, we just wanted to let you know that we do continue to meet with CAN providers every month. We feel this particular issue could be removed from the issues log because for us to receive additional resources, we know the steps we need to go through to make that happen. So, Mr. Chairman, that's up to you and the members of the committee, but we would respectfully ask that this particular issue be removed.
Janice, we will, if there are no objections from the committee, we will have that stricken from the log as well. And seeing none, we'll strike it.
Thank you. Number 18, at the risk of repeating myself from the last meeting, Leslie talked about the final settings rule. I'm not sure we've talked about that enough, but Amy, Commissioner Penrod has included that in her discussion this afternoon, and I think you all have now added that as a default item every single time we meet, which I think is a good thing. Amy will provide you with an update with more details on the final settings rule. We are very much making progress, and she will be happy to report that. From our vantage point, it's up to you. I mean, from our vantage point on item number 18, we will report to you every month in the afternoon. But if you want to leave that on the log sheet, we'll let you know during this process that the final settings rule, we are making progress. So up to you if you want to keep it on this log, Mr. Chairman, or not.
Janice, and if it's okay with you, I think if we leave it on there, at least it'll be not out of sight, out of mind for us.
Yeah, and I actually agree with you, Mr. Chairman, on that, because at that point in time, we want to make sure that we talk about final settings rule every chance we get, every opportunity we have. On number 19, oh, we said no further updates. Okay. Well, I'll just let you know that this afternoon, I will share with you again, we do have still one facility in receivership, just one out of the 22. So that's up to you also, Mr. Chairman, if you want to remove that from the log sheet. But it might make good sense to remove it once we no longer have any facilities in receivership, but that's up to you.
Yeah, Janice, I think I'd rather wait until after we're to zero on that.
Okay, sounds good.
Mr. Chairman.
Representative Landwehr.
Thank you. And you may cover this later as well, but there was discussion, and I want to say perhaps it was in the KanCare Oversight Committee this last year, that there's the potential, and I think you had some teams out in some of our long-term care facilities that may be having some financial issues, and we're trying to avoid a receivership situation. Can you update us on that?
You know, Representative Landwehr, if you don't mind, I might defer to Scott Bruner to see if Scott this afternoon can give us an update at the present time, and maybe even Secretary Howard can help me answer this. At the present time, we have not received any requests, if you will, for receivership assistance. I'm not sure that's probably the best way to present that, but at this point in time, we haven't heard from facilities. Now, we do know facilities, some have closed, but that's not unusual. I mean, we have facilities who close. We have change of ownerships, facility closures. That's not unusual. What is unusual is for a facility, from our vantage point, need to be pulled into receivership. But I think Scott can probably give you a better update this afternoon, or the secretary, on where we are with a couple of facilities that CMS had pulled into temporary management. So Representative Landwehr, if you don't mind, I'll defer to the secretary and Scott this afternoon.
That'll be fine. Thank you.
I'm out of the loop on that one. Number 23, the specialized medical care update. I think there's already been a lot of good discussion on that particular issue, but we just simply want to let you all know that if you do need information about the fiscal note to raise that to 48, that being the rate compared to the 39, I do believe, Representative Carpenter, that information has been shared with your team on how much SGF would be required to raise that rate to 48, just FYI. So number 25 is Senior Care Act. Mitzi McFatridge brought this up before she retired. In order to change the eligibility for the Senior Care Act, we would need statutory action to do that. But we do want to take this opportunity to say thank you. I do believe $3 million was included in your appropriation bill for the Senior Care Act program, and we appreciate that very much. Okay, number 29. Number 29, Marissa, is next for us, and that is the nursing facility visitation. While I have agreed to respond to this, Scott Bruner and Lacey are our experts, and we did want to let you know in the issues log that KDADS and CMS issued a revised visitation guide. This is very specific to nursing facility visitation. It was issued in March of 2021. Scott will have more details for you in the slide deck this afternoon, but there was visitation guidance that was sent in March. So that's good news. Number 31, the MFP program. I am happy to report that Commissioner Amy Penrod is working closely with stakeholders to draft a program to resurrect, if you will, the Money Follows the Person program in Kansas. We thank our advocates. We do feel that the federal opportunity is the results from a lot of strong advocates across the nation asking for the MFP program to be strengthened. We do believe that is happening, and we're glad to be a part of it. Okay, number 33. The IDD provider rates. It's my understanding you all did include a rate increase in your appropriations bill, so we thank you for that. We will get going on what we need to do internally to get that rate increase available as quickly as possible. Okay, let's see. Number 41. Again, this is Scott's issue, but I'll go ahead and cover it for him, and he may want to speak in more details this afternoon. But number 41 is the use of temporary aids. It's my understanding that KDADS has extended the current temporary aids authority through May 28th of 2021. So that'll get us another month or so here. Through EO 21-12. So we've been working closely with the stakeholder groups and the course sponsors of the training to ensure that enough courses are available for temporary aides who want to enroll in the CNA courses are given that opportunity. Number 42, again, from our vantage point, this is from Nick, and it speaks very specifically to mobile crisis, which we've already talked about a bit, but at the risk of repeating ourselves again, which I'll try not to do, the mobile crisis system, if built in Kansas, as it's built in Kansas, we do believe can help speak to some of the IDD issues, concerns, and I won't say more. I've said enough. Unless there are questions. On number 43, again, this is the, this is the brain injury. Okay, so we have formed a work group. I think you all are aware of that. We've formed a work group. In fact, I think you asked us to, and talk about potential policy changes. We are doing that. We can't thank you enough for funding, agreeing to the funding for this particular waiver service. And we also thank the governor's office for the GBA. So we will keep you posted on the progress of this particular work group when it comes to the potential policy changes to ensure that this waiver is and continues to be a short-term, if you will, rehab waiver. Oh, looks like there's a question, Mr. Chairman.
I don't see the question.
Yeah,
so.
no, it's your vice chair again, Mr. Chairman.
Representative Landwehr, go right ahead.
Okay, on the funding that was put in, that is only for 1 year. So what your work group is going to look at is what the needs are as it expands out there, because as we expanded from it being strictly a traumatic blow, I don't remember what the term is for that. When we expanded it, then we started picking up individuals that were stroke victims, et cetera. And we've also got more people that are actually providing the services. So you'll be looking at what that long-term impact is, but our funding's only for 1 year so that we do not have a waiting list. Is that correct?
Representative Landwehr, I was hoping to get through this entire presentation without having to make a footnote here that I was out for a couple of weeks, right in the midst of the heart of the legislative session. So I am kind of embarrassed to say I will have to defer to the Secretary and Amy Penrod on that. They will know, and I apologize that I do not. But I've done my best to get up to speed, but you caught me on that one, Representative. So I don't know the answer to that question. I do know that Amy is working hard to pull this group together and focus on the policy. So let me defer to Amy, and I'm sure Laura will know this afternoon also. So I apologize for that. I don't know.
All right, thank you. No, you're fine. Thank you.
And then number 44 was our next response, and it has to do again with the waiting list. So it may very well be represented, Mr. Chairman, that as we combine the waiting list issues, that again, we pulled a group together to study the needs of the folks on the waiting list. And if I may just go to number 45, where Linda Mowbray talked about uncompensated care. From my vantage point, I very much appreciate Sarah, Medicaid Director Sarah Fertig's comments on this. And I would just add to Sarah's comments that it feels like this particular issue, number 45, may be one of those opportunities where HCBS, as it is spotlighted at the federal level, as Amy Heighton noted in her testimony this morning, and so did Sean Gatewood, that as HCBS is spotlighted at the federal level, this may be one of those opportunities where CMS could rethink the notion that HCBS eligibility can't be retroactive. The nursing facilities eligibility can be retroactive, but for community-based services, eligibility is not made retro. So maybe this will be one of those policies that can be revisited at the federal level to make HCBS more responsive than it is currently because of this restriction. So we appreciate Linda bringing it to the table, and we hope that CMS rethinks this issue. I think other than that, on issue number 46, where Haley was talking about the bed tax or the bed, oh, good grief. What am I trying to say here? The number of licensed beds and how facilities can change their number of licensed beds would require legislative action. And again, I'll let Scott speak more to that this afternoon, or unless you all have questions now. I think Scott's actually on the line. So with that, it wraps up my presentation unless there are questions.
Janice, thank you very much. I do not see any further questions for you at this time. Committee, we do have the MCOs available for questions if you have any for them. Not seeing any. Committee, that does conclude our morning session. So we are scheduled for lunch at 11:30. We're going to get a little bit early break, so we'll go ahead and recess for lunch, and we will be back at 12:30 sharp. So we'll see everybody at 12:30 sharp. Thank you. Okay, everybody, we are now back in session with the Bob Bethell Oversight Committee. Next on our agenda will be Megan Leopold, Fiscal Analysis for Kansas Legislative Research Department. She's going to give us an update on the human consensus caseload for our spring estimates. So Megan, welcome to our committee.
Thank you, Mr. Chairman. The information that I'll be presenting can be found in this tan-colored memo that you should have just received. It contains details beyond what I'll discuss, and on the back page there's a table that is a nice way to combine and consolidate a lot of the numbers that I'll be talking about. So I'm going to review the human service caseload estimates. These are the estimated expenditures for the state's human services caseloads. The caseloads include the state's entitlement programs. So these are programs that are required by federal law to serve anyone who meets the eligibility criteria for that program. So in Kansas, these include TANF cash assistance, foster care, KanCare medical assistance, KDADS non-KanCare, and this includes assessments for HCBS waivers and state hospitals, as well as nursing facility fee-for-service. A consensus team meets twice a year to create updated estimates.
Megan, can I interrupt just for 1 second?
Sure.
Marisa, I just received a text that the ones online do not have a copy of this. Is that true, or? Oh, okay, thank you. Megan, go ahead. Thank you.
So the consensus team meets twice a year, once in the fall and once in the spring. The team consists of the Division of Budget, Legislative Research, as well as representatives from the agencies that are included. That's DCF, KDHE, and KDADS. The team most recently met on April 19th, and we created revised estimates for fiscal year 21 and fiscal year 22, and that's what I'll be going over today. The starting point for these estimates was the budget that was approved by the 2021 Legislature in House Bill 2007. So anytime you hear me saying there's an increase or a decrease, it's an increase or decrease between the approved budget and then the new estimates that we've come up with in April. So I'll go ahead and start with fiscal year 21. The total human service caseload estimates for fiscal year 21 was a decrease of $354 million all funds, and that included a decrease of $190 million SGF below the approved budget by the 2021 Legislature. For TANF, or Temporary Need Assistance for Needy Families, this was an estimated expenditure of $11.5 million, and that's all federal funds. This was a decrease of $2.6 million below the approved amount, and that decrease is generally due to the availability of COVID-19 stimulus funds that can prevent applicants from being eligible for TANF cash assistance and led to a decline in applicants. For foster care, the estimated expenditures were $10.5 million all funds, and that's 3.4 SGF. This decrease is generally due to lower estimated cost per child, as well as the $8.3 million that DCF will receive from the St. Francis repayment process, and that will be money that's put towards foster care program. For KanCare Medical, which includes expenditures for both KDADS and KDHE, the fiscal year 21 estimate for KanCare Medical is $3.5 billion all funds, and that includes $830 million SGF. This was a decrease of $334 million all funds and a decrease of $178 million SGF. The primary reason for the all funds decrease was a decrease in capitation expenditures. When we met in the fall, we had about 6 months of actuals from the public health emergency, and there were two things that we were looking at. One was how the pandemic was going to affect enrollment, and the other was a federal requirement that comes with the 6.2% FMAP increase that says that Kansas cannot unenroll anyone from Medicaid until the public health emergency is ended. So at the time, we anticipated a population trajectory, and in the spring, when we had 6 more months of actuals, we came to realize that we had estimated a little bit high. So most of the decreases that you see within the KanCare Medical came from that population estimates that were higher in the fall than they were in the spring when we had more updated data. We also saw a decrease due to mid-year rate adjustments for MCOs that were about 2% lower than were anticipated. Other reasons for the all funds decrease include payments for the health insured provider fees. These were payments that were originally anticipated to be paid in 21 that were shifted to fiscal year 22. And there's also a decrease to fee-for-service expenditures, and that was due to lower utilization of services. The state general fund decrease in fiscal year 21 is generally attributable to the extension of that 6.2 increase to the FMAP. The fall estimates were assuming that that increase would be applicable to the first 3 quarters of fiscal year 21, but since then it's been extended, and now in the fall we included that 4th quarter with that increase. The SDF reduction is also due to an increase of about $12.9 million available assistance fee fund. That's the HMO privilege fee fund that was used to create some SGF savings. One increase to the all funds and the SGF expenditures in the spring estimates include a temporary increase of $15 a day for nursing home reimbursement rates. This was a continuation of a daily rate increase that was first provided at the beginning of fiscal year 21 using federal funds. And it was intended to help alleviate some of the costs associated with the COVID pandemic. For fiscal year 21 KDADS non-KanCare, the estimate is a decrease of $6.1 million, and that includes a decrease of $8.2 million SGF. This decreased expenditures was generally due to retroactive fee-for-service payments, and that was a result of fewer delays in eligibility determinations for pending claims, as well as possible decreases in individuals that are entering nursing homes due to the pandemic. I'm happy to stand for any questions about fiscal year 21 before I move on to fiscal year 22.
Committee, do we have any questions for Megan on fiscal year 21? Okay, not seeing any. Megan, go ahead and proceed, please.
Okay. For fiscal year 22, the estimate for all caseloads is $4.1 billion, all funds, and that includes $1.3 billion from the state general fund. This is a decrease of $269 million all funds and $142 million SGF. And again, that's below the fiscal year 22 approved amount in House Bill 2007. For TANF, the estimate is $10.9 million, and that's all federal funds. And again, this is a decrease of $2.6 million below the approved amount. For foster care, the estimated expenditures were $266 million all funds, and that includes 181 SGF. This was an all funds decrease of $891,000, including 130,000 SGF. The all funds decrease, again, is partly due to that $4.1 million that DCF received from the St. Francis repayment process, as well as maintaining the fiscal year 2022 case management provider rates at the fiscal year 2021 level. For KanCare Medical for fiscal year 22, the estimate is $3.7 billion all funds. That includes $1.1 billion SGF. This is an all funds decrease of $262 million and an SGF decrease of $140.3 million from the approved amount. As in fiscal year 21, the all funds decrease is again largely due to that lower than anticipated population growth. Also, when the public health emergency ends, KDHE had some updated information about how quickly they would be able to remove those members that were no longer eligible at the end of the public health emergency, and that timeline has been sped up a bit, again lowering the population more quickly than anticipated in the fall. Also contributing to the all funds decrease was a reduction in risk corridor payments to MCOs, and that was a result of reduced utilization of medical services during the pandemic. The all funds decrease is partially offset by a projected 3.2% rate adjustment for MCOs, and that's based on cost trends. Is also offset by those HIP payments, health insurance provider fees, that were shifted from fiscal year 21 to fiscal year 22. Fiscal year 22 also includes the implementation of the support and training to employ people successfully, or the STEPS pilot program. This is a program that provides supportive employment to individuals who meet Social Security Administration definition of disability and are not being served by a home and community-based waiver. The State General Fund for KanCare Medical in fiscal year 22 was largely due, again, to that population decrease. It was also due to the extension of that 6.2% FMAP increase that in the fall, we did not include any of fiscal year 22's estimates, and now it's been extended through the first quarter of fiscal year 22. There's also an increase of $17.5 million from the Medical Assistance Fee Fund, that HMO Privilege Fee Fund, that was used to offset State General Fund obligations. The State General Fund savings were partially offset by the shift of those HIP health insurance provider fee payments from 21 to 22. The shift did increase the SGF due to some outstanding payments that have exceeded the timeline to be eligible for federal match. There's also a decrease to the State General Fund of $13 million reduction in funds available from the Medical Programs Fee Fund. And finally, for KDADS non-KanCare for fiscal year 22, the estimate is $40 million all funds. That includes 26 million SGF. This is a decrease of 3.4 million all funds and a 1.5 million SGF. And this decrease was mainly attributable to continued decrease in nursing facility fee-for-service expenditures, largely due to the pandemic. I'm happy to answer any questions about caseloads.
Megan, thank you very much for that. We'll open up for questions. Representative Carpenter.
Thank you, Mr. Chair. I could be here all day with Megan answering questions that I have here. I did see the medical fee fund that we use to pay CHIPS, and so there were more money in that. So are we going to rely less on that?
We took the amount that was used from that fee fund down by, I believe, 13 million in fiscal year 22. And that was for a variety of reasons.
But weren't they going to be short? Wasn't CHIPS going to be short, and that's what they paid CHIPS out of?
I don't know how much of CHIP is paid from that fee fund, but that is what they were intending to pay it from should they not have received any SGF support in fiscal year 22. The agency had an enhancement request to pay that from SGF rather than that fee fund because they felt like the fee fund couldn't support those expenditures.
So now with this increase in the fee fund, they should be able to pay that expenditure out of the fee fund?
I can't speak to that, but my understanding is that fee fund is generally to be used for caseloads expenditures, and CHIP is not included in caseloads.
Okay. All right. Thank you. Thank you, Mr. Chairman.
Senator Fagg.
Thank you, Mr. Chairman. Could you help me on the services covered by KDADS non-KanCare? What items go under that category?
So KDADS non-KanCare is generally the medical portion of KDADS services. So for example, the home and community-based waiver, they're not included in caseloads. They're not an entitlement program, but the ability to be assessed for the waiver is an entitlement. So that's that medical portion or the entitlement portion of that program. Another example is for state hospitals. Anyone is entitled to an assessment for a state hospital, but state hospitals are not included in caseloads.
Okay, thank you.
Representative Ballard.
Thank you, Mr. Chairman. I want to go back to temporary assistance for needy families. All right. So that the estimate for the temporary assistance for needy families program is 10.9, all from federal funds. Okay, we get 102 million as a block grant, right? So that's what's confusing to me right now, because it says and foster care. But normally we're like 102 million is the block grant that we have for TANF.
So this TANF is only the cash assistance portion. Does that answer your question? Sade is here. She is much more knowledgeable on TANF than I am. So if that doesn't answer your question, she might have additional information.
Okay.
Chardonnay.
Good afternoon. My name is Sade Kane with Legislative Research. They do receive, I think, 102 million. I'd have to look into how that is broken down and if that was a one-time payment and they are pulling from those funds, or if it is an ongoing payment, though.
Okay. Or that, or I can ask later on Secretary Howard, you know, maybe that would do it, because now this is confusing to me when I'm looking at the figure here. So, or what the St. Francis repayment process is. So I'll cover that with them. Okay. Thank you.
Well, if I may, the St. Francis payment is for foster care only. So because TANF, cash assistance, and foster care are both in DCF, that's the only reason why they're together. But the St. Francis is from is from foster care.
Gotcha. Thank you.
Okay, not seeing any further questions. Megan and Sharnae, thank you very much for that. Committee, we will now turn to Secretary Norman. He is going to give us an update for KDHE. Secretary Norman, are you with us?
Yes, I am. Thank you, Mr. Chairman, and thank you, committee members. Can you hear me okay, Mr. Chairman?
We can. Thank you, and welcome to our committee.
Thank you very much for allowing us to speak. Back one slide, please. Just an overview of the agenda that we want to talk about for the next hour or so. As I'll introduce and refer to a few topics about COVID-19. We get no shortages of questions about this, and does obviously have impact on the KanCare program, as well as a lot of other aspects of the state. So I'm going to comment briefly on that. I'll turn it then to Sarah Ferdig, our state medical director, to talk about those items you see listed there, and then to our director of operations for Medicaid, Chris Schwartz. Next slide, please. I think the COVID-19, particularly as we've gotten into deeper into the vaccine delivery and administration, I think we're seeing some light at the end of the tunnel. We certainly, compared to other states around the country, most especially Michigan, New York, Jersey, and Florida, that has seen quite a spike, we have so far dodged that at this point in time. We're all crossing our fingers and holding our breath just a little bit, in the sense that we have leveled off at a new plateau level. I'd like to see us continue to drive the numbers down. The numbers are not insignificant. We're still having 200 to 300 new cases a day, a couple of deaths per day on the average. And we take that very seriously, obviously. But I think that we're with the vaccine. I want to point out one thing that I think is quite important, and that is, even as recently as 2 weeks ago, we were in a relatively vaccine deficient position, both because of the amount provided by the federal government and also difficulties. And this, it's always hard to get all the doses vaccinated into people's arms. But over these last 2 weeks, very curiously, and I just got off the call with General Perna of the White House and the four states of us in Region 7, Nebraska, Iowa, and Missouri are seeing the same trend, which is a decreased demand for the vaccine. And those states, just like Kansas, about half of the counties have paused on any request for new vaccine because they have enough in inventory. We have, at this point in time in the state of Kansas, as of today's numbers, 1.88 million doses have been administered to Kansans. That is 64,500 doses per 100,000 persons, or 64.5 per 100 people. That has us in the CDC COVID tracker in the top tier. So I'm pleased that we've did admittedly play some catch up, not only in terms of the vaccination, but the data recording. The first doses are over 1 million, so approaching 40% of Kansans, and the second dose approaching 700,000 for complete immunization. So we're catching up to where we want to be. One of the favorable aspects and one of the things that driving this success is a fairly low rate of positive tests. 2.9% of the tests now for the state in the month of April positive for COVID-19. And you'll recall that in the darker days in December, January, we were in many regions up to 15 or 20% test positivity. The second item is somewhat sobering, but I think we are understanding the variants. The variants meaning there's what we refer to as the wild type of COVID-19, which accounts for the majority of the cases in the state of Kansas, unlike Michigan, for example, where the variants account for a higher majority of the cases that they're seeing. We have all the 4 variants of concern, and I won't use the numbers because it's confusing, but it's the United Kingdom, South African, Brazilian variant, and the California variant. And but they have not become the dominant strains in our state. We have remarkably upticked the amount of capacity for testing for the variant strains. Our Kansas Health and Environment Lab has tripled its capacity. We have also other laboratories, commercial and state, that help us with the genomic sequencing. And one of the reasons that this is important is because we're still understanding these variants and want to get our handle around, are they more infectious? Are they more serious clinical manifestations? And what does that do regarding the guidance for the vaccine development and use? They have not become the dominant strains, but we are watching for them and monitoring very closely. And we also do case investigation and contact tracing a little different once we know that there's a variant that's been identified. We're also, and you have heard me and probably read in the news, that we're doing wastewater testing as well for viral particles and fragments. And we now have the capacity and are doing the variant testing of the wastewater stream as well, so that we, in a community that has an uptick, if we need to assist the local organizations and the communities to do an enhanced testing, that we can bring in some mobile labs and the like to assist with that. Third bullet item, also very encouraging. Hospital capacity is not being spent for the most part on COVID-19. I was on a call with the rural and smaller hospitals and the critical access hospitals just 2 days ago. They're doing fine, a few cases here and there. They're especially doing fine in their staff. Their staff are greater than 90% vaccinated for the most part. And that is true also for the larger hospitals as well. And where some of the larger facilities had more than 100 people out at a given snapshot in time, again, back in the darker days, which I define as pre-vaccine days, they now have, it's very rare to have somebody out with COVID-19. So the staffing and hospital bed capacity is no longer a problem, and I hope it stays that way. Finally, the Johnson & Johnson vaccine is something that has us concerned. There's been 6 cases of an unusual central venous thrombosis that occurs in the brain. 6 cases out of about 6.8 million. So literally 1 in a million, less often than 1 in a million, but they're a significant complication. So a week ago Monday, we put the Johnson & Johnson vaccine on hold, on pause, actually. We weren't required to do that. The FDA and CDC said they thought that would be justified. And we chose to do that because, one, we have 2 other perfectly good vaccines, the Pfizer and Moderna. Yes, they're a 2-dose series rather than the Johnson & Johnson, which is just 1 dose. But, and we have enough vaccine to backfill for Johnson & Johnson, which, by the way, wasn't making up the lion's share of our vaccine anyway. because the Moderna and Pfizer were the larger quantities coming in, and really not associated with the complications. So where we are now with that is that the FDA and the Advisory Committee on Immunization Practices of the CDC is evaluating it. I think that we'll hear on Friday afternoon what the Johnson & Johnson product will be recommended. Again, those are very small numbers. The complication is significant, and we'll see. I have a hunch that it will come out as being approved for continued use, but because of the fact that it was mostly 18 to 40-year-old women that were involved, there may be some patient selection criteria involved in the counseling before the vaccine is given, and informed consent, of course, is always required before administering anything like that to a person. So in summary, Mr. Chairman and committee, I think we're moving the right direction. We have a hard push to inform the people about the vaccine. There's communities, some communities are less accepting of the vaccine than others. We tried to reach them through their churches and through the Kansas Leadership Centers, helping working with the Hispanic and Latino groups. And again, the Kansas Leadership Center is blanketing the state with community conversations, again, with local elected officials and church leaders, business persons and the like, to make sure we can keep the conversation going. Because I think that we would really like to get to 70–80% or more of eligible people to receive the vaccine. Preemptively, I'll just say that you hear chatter out there about the vaccine passport. We have no interest in the state of Kansas for vaccine passports that will allow or disallow persons to do things. Whether businesses choose to do that or not is not for us to decide, but we have no interest in pursuing that. The wastage, something we watch a lot, 99.8% of the vaccine that has come into Kansas, whether it's some of it, a little bit of it still in inventory or most of it obviously being administered already, 99.8% has not been wasted. We have had 3,994 doses that, due to expired, shortages in the vials themselves, or a drop vial with breakage, but that's only 0.2% of the total allocation that we've received. The vaccine is still coming free to individuals with no out-of-pocket expenses. Their insurance company can be billed for an administration fee, which is a modest fee that to help the medical offices to cover their time and personnel cost. Kudos to the managed care organizations. I know we'll hear later from them today, and you will hear later from them today. They've adjusted, and I think, again, same theme as last time we talked. I think they've been very, very creative and innovative with lots of enhanced services that during this very difficult time, admittedly. So with that, Mr. Chairman, I will be quiet and turn it over to Sarah Fertig when you choose to do that.
Okay, Mr. Secretary, if you don't mind, if you would just hold on. I know Representative Landwehr had a question for you, and there's a couple other questions from the committee. And I had one for you as well. I don't know if you were listening this morning, but the Medicaid Inspector General, Stephen Anderson, had touched on the capitation payments that were being made after the beneficiary was deceased. And he said something about like $1.3 million was paid out, but they were able to capture 1.1 million back. So I have a couple questions on that, if you don't mind. The first one, have you guys been able to capture that 200 million that wasn't captured earlier? And he also had said something about the key system is what caused that error. Has that been fixed, or is there a plan to get that fixed where this doesn't continue to happen? And thank you.
Yeah, I don't think I'm the best position to answer that, sir. I would rather have either of the next two speakers respond to that. They're the ones closer to it.
Sure, thank you. So next will be Representative Landwehr.
Thank you, Mr. Chair. Secretary, could you provide us with a copy of the information you're reading from that provides details on your bullet points, please?
Sure, it's just handwritten chicken scratch, but I'll be happy to transpose that into a written form and provide you that.
I just think it would be helpful for us to see something besides bullet points so that we can, share with people. And I'm still a little bit disappointed that after, the precautions and everything that everybody's taken and the vaccines that have happened, that you still can't appear into the committee in person. That's still a little bit disturbing. So thank you, Mr. Chairman.
Thank you, duly noted.
Representative Lynn.
Thank you, Mr. Chair. I'm kind of curious. When you're seeing a reinfection, do we tend to see it as a result of a different variant?
We have seen reinfections, and by and large, it has not necessarily been because of the variants. We did have a case last week involving that, and I think it is worth mentioning. There was a staff member at a skilled nursing facility who came to work ill, and this addresses your question, ma'am, which is wrong, by the way. They shouldn't come to work ill. They were tested, and not only were they positive for COVID-19, but it was one of the variants. Matter of fact, it was the Brazilian variant. Of course, working with the local organization, the local health department, and the nursing facility, we assisted with testing every 3 days all the residents in that nursing home. That one ill person had come in contact with quite a number, 2 of whom were infected. One 85-year-old fragile woman and another 95-year-old fragile woman, both residents of the nursing home. They both came out positive for the virus, and both of them were the same exact variant, the Brazilian variant, but neither of them were ill. Neither of them had any symptoms at all, and breezed through it had they not been routinely tested, would not have even known it. And they had both been fully vaccinated. So to your question, a good example of avoiding hospitalization and perhaps death, because those are very fragile people that prior to the vaccine, I think would have been probably become ill. So I think the best summary is that the people that are vaccinated can still become infected. It doesn't happen very much. Again, we hear 95% of the time it shouldn't be, but that's still 5% of a very large number. I could do the math, what 5% of 3 million is, for example, but that still is something that we can't let our guard down when it comes to testing those people that we identify through case investigation. But the fact that we can dodge hospitalization and critical illness and death, I think, is something that's really a strength of the vaccines.
So the natural immune response from the original variant seems to be effective against the new variants as well.
Yes, and to your question, one of the things that has been shown, and I think it's related to what you're asking, ma'am, is that the naturally occurring infection gives a certain amount of immunity through neutralizing antibodies. The vaccine, as recently published in the Journal of American Medical Association, has a tenfold increase of the antibody over the naturally occurring infection. So you can't rely on naturally occurring infection for immunity. And then secondly, if you've had the naturally occurring, and 306,000 Kansans have gotten the infection prior to the vaccine coming on or so. So 1 out of 10, those people should still be vaccinated.
Okay, thank you. Thank you, Mr. Chair.
Secretary Norman, I do not see any further questions from the committee. Thank you for your update. And I believe Sarah Furtick is next. Is that right, Sarah?
That's right. Thank you, Mr. Chairman. So just to give you kind of a roadmap of what I'm going to talk about, I'm going to talk about some recent federal legislation and then give you all an update on some of the recurring topics that we address at most Bethel meetings, and provide you with a focus on what has changed since February. Marisa, could you move the next slide? Thank you. All right, so at the top, I'm sure a lot of you have heard about the federal legislation that the president signed a little over a month ago called the American Rescue Plan Act. There were a couple provisions of that bill that have Medicaid implications, and so I've highlighted 4 of them here for the committee's information. Some of these I'm sure you're aware of already. Very exciting for us. The first bullet point here is that beginning April 1st of 2021, states have the ability to pay for COVID-19 vaccines for Medicaid beneficiaries with 100% federal dollars. That was exciting to us for a couple reasons. The biggest one, though, is that our providers have been asking us since December to pay Medicare rates for COVID-19 vaccine administration. We were unable to do that because we couldn't afford it financially. However, with this new authority to use 100% federal dollars for this, we are newly able to pay Medicare rates for COVID-19 vaccine administration, and that increase is substantial. Medicaid's typical rate for vaccine administration for an adult is about $14.15 per shot. Medicare recently increased their rates for COVID-19 vaccine administration to $40 per shot. So obviously that is a big impact for providers. We are in the process of rolling this change out. This probably won't come as a surprise to any of you, but the mechanics of trying to do something simple when it comes to Medicaid is something sometimes more complicated than one would expect. So we are awaiting CMS approval to increase our rates to Medicare rates. And we intend to let providers know as soon as possible whenever all of these details get ironed out. But this is our plan. The second bullet point talks about a new authority in the American Rescue Plan Act that would allow states to make a policy choice to extend coverage for pregnant women through 12 months postpartum via a state plan amendment versus an 1115 waiver process. Practically speaking, what that means is that they're streamlining the administrative hurdle at the federal side that a state would have to go through in order to make that policy choice. This is a topic that's been getting a lot of attention on the state and local level, so we're researching that. There's also a new incentive for Medicaid expansion for states who would newly expand. That would be an additional 5% base FMAP for the first 8 quarters of expansion. And, you know, because it's based on a percentage, an extra percentage of FMAP, the precise number of dollars that could be brought into Kansas as a result of that vary. It depends on the methodology of the estimates. It's not a stagnant set number. It would depend on the number of federal dollars we're drawing down during that time frame. But estimates range from 330 million. Our estimate is about 460 million. Yesterday, I became aware that Manat Health did a review, and their estimate for Kansas is $468 million over 8 quarters. Another key part of the American Rescue Plan Act is an additional 10% federal funding for HCBS and PACE and home health for the time period of April 1st, 2021 through March 31st, 2022 only. So this is a 12-month only enhancement for HCBS, PACE, and home health. KDADS is kind of studying what would make good options to try and invest some more money into those areas. They might have more information for the committee later. Mr. Chairman, if anybody has any questions on this, I'd be happy to answer them. Otherwise, Mr. Chair, if you would like for me to continue, I'm happy to do that as well.
Kara, why don't you go ahead and continue? I do not see any questions from any members of the committee.
I think
so.
Representative Landwehr has a question.
We do have one, sorry. Representative Landwehr.
Okay. Sarah, on the 12 months of postpartum, so that means by going through as a state plan amendment that there's no budget neutrality issues, is that right?
We don't think this would cause a budget neutrality issue with us, Representative Landwehr. State plan amendments can affect budget neutrality. What this would do is not change eligibility. It would we'd basically be spending roughly the same amount, I think, that we're spending on pregnant women just for 10 months longer than we currently are. So the number of folks that we would be carrying on the pregnant women eligibility group would likely increase because currently about 60% of Medicaid moms fall off of eligibility 60 days postpartum. So we would be carrying more folks for 10 months longer. However, in initial discussions with our actuaries, we think this change would have negligible impact on budget neutrality and might actually help us to a minor degree by reducing the overall capitation rate for pregnant women when it's extended over additional 10 months postpartum versus cutting it off at 60 days now.
So do we know when we would have a definitive answer on the budget neutrality issue?
Our actuaries are studying it right now. They've asked for an extra 2 weeks to try and figure out what that rate would be.
All right, thank you.
You bet. All right, Mr. Chair, I would move on to our next slide here. Everyone's favorite topic, budget neutrality. I'd be remiss if I didn't bring it up again. So at the February meeting, I provided probably more information than anyone wanted on budget neutrality. This time I decided to kind of pare it down a little bit and, just kind of as a reminder, our budget neutrality cap is the amount that CMS has calculated that we are allowed to spend per Medicaid member per month for the life of our 1115 waiver, which ends at the end of calendar year 2023. The second bullet point here shows you what our current per member per month caps are for calendar year 2021 across two very broad eligibility groups, adults and children, and then aged, blind, and disabled, and long-term care, ABD and LTC. So that kind of shows you where it is. And practically speaking, what that means is that when you look at all of the eligibility groups that fall within adults and children, the average amount we're allowed to spend per member per month is around $375 a month. So when we talk about budget neutrality, we always look to see what a policy change might mean for our expenditures within those two broad eligibility groups. And on the third bullet here, what I mentioned is that last fall, we submitted a request to CMS for a technical correction to our budget neutrality calculation. We thought they'd shortchanged us by about $395 million. We received news about a month ago that CMS approved the technical correction, which is good news. However, our actuaries are concerned that the way CMS applied the correction isn't as useful to us as we had hoped. So they're continuing to study that, and we will update the committee as we go. And if there's any questions on the budget neutrality front, Mr. Chair, I'd be happy to pause here for those before we move on.
If Representative Landwehr doesn't have any questions, I do not see any. Whoops, we do.
Actually, I do, Mr. Chairman. I think it would be good, Sarah, for as as the actuaries are trying to deal with this issue, that you keep not only the Bob Bethell KanCare Oversight Committee up to date on it, but make sure that all the chairs and committee members of Senate Ways and Means and the House Appropriation are aware of it, and especially the budget chairs that have those budgets.
That's a great suggestion.
Yeah, and if you have anything that you can provide, especially because we all go in next week, I think the Senate starts working on their budget on Monday and the House starts working on theirs on Tuesday. Thank you.
Thank you, Representative. That's a good suggestion.
And Sarah, we do have another question from Representative Carpenter.
Thank you, Mr. Chair. Sarah, on this per member per month, the current cap that you're talking about hadn't been raised. How much would that have affected our budget neutrality?
That's a good question, Representative Carpenter. And Mr. Chairman, that kind of gets to the core of what our actuary's concern is. What we had anticipated is that when the technical correction was approved, these amounts, these per member per month caps that are shown on this slide would be increased in the aggregate to the tune of $395 million. That, however, is not what CMS did. They included that in a separate line item in our budget neutrality workbook. And the concern is that operationally, that additional cushion, it's possible that we might not be able to use that as we'd intended to help, keep us within those caps across those Medicaid eligibility groups. So we're continuing to study that, Representative Carpenter, and we just had a meeting yesterday with our actuaries for more updates. And so we probably need to seek some more information from CMS to make sure everyone's on the same page about how this operates.
And just to follow up for that, did they change the capitation rates any?
No, that was not affected.
Okay, very good. Thank you.
Sarah, I do not see any further questions from any of the committee members, so you may proceed.
Thank you. All right, so an update on the Healthcare Access Improvement Program, or HCAP for short. This is the Hospital Provider Assessment Program, and the assessment funds that are generated are used to draw down federal matching funds. And we use those additional funds to increase rates for hospitals and for physicians. So just a quick recap of what the HCAP program is. And as just to remind everybody of the history here, about 2 years ago, my predecessor, Adam Proffitt, submitted a technical amendment request to CMS that would allow us to implement the changes that were made to the HCAP program by the legislature a couple years ago. And doing so would allow us to further bolster those rates and support physician rates and hospitals even more. CMS told us in May 2020 that they were not going to approve that technical waiver amendment, but they didn't formally deny it. If you look on the CMS website, that request still shows as pending. It was never formally denied. So it's still considered live, and we are continuing to advocate for this. We've had conversations with CMS. We had some in January, I think again in March, and we're continuing to advocate that this is something the state really needs, and we really want that amendment to be approved. In the meantime, the technical correction that CMS approved last month is not enough to implement the HCAP changes in statute as were contemplated by the legislature. So if we were to truly enact what the changes that the legislature made to the HCAP program statutorily, we really need that waiver amendment to be approved. So we're continuing to work on it. And if the waiver amendment is not approved, if we make any adjustment to the HCAP program at all, we're going to have to shoehorn it into our existing budget neutrality limits. Marisa, could you go ahead and flip the slide? Thank you. All right, so the protected income limit, I originally was going to not give an update on this, but I think it's worth commenting on now. So as of January 1, 2021, our regulation took effect, which codified the protected income limit at 150% of SSI. Since February, we were pleased to provide proponent testimony for House Bill 2249, which would codify the same policy change, but that would be in statute. And we would also note that the conference committee report for House Bill 2007 did include language to increase the protected income limit for the PACE program only for FY22. And so if that ends up becoming law, what we'll have to do is revisit that regulation, because as you can see, the bolded italicized language refers to PACE and HCBS. So we will have to do a regulation amendment to implement that on the legal side. And I would also add, changing the protected income limit has no effect whatsoever on budget neutrality. It's one of the only things we can do with regarding Medicaid that will not affect budget neutrality. So I'm always happy to talk about it. Moving on, an update for KanCare Kansas. So our program is about 1 year old. We had our 1 year anniversary.
Sarah?
Oh, yes.
I apologize, but Representative Carpenter had a question on that last slide. Would it be okay to go back to that real quick?
Absolutely.
Please. All right, thank you.
Yes, Sarah, this is in regards to the protected income limit or the client obligation. So would the increase to 300% have any effect on our budget neutrality?
None at all, Representative Carpenter. That's because our budget neutrality is calculated without reference at all to the client obligation. So we can tinker with the protected income limit as much as we like, and it will not affect budget neutrality.
Okay, very good. Thank you.
Sarah, just a follow-up question for me. What about the out years?
With regard to budget neutrality or with regard to protected income limit?
How both? If you did that temporary I believe, on the protected limit. How would that, if it doesn't affect budget neutrality now, what about the immediately, what about the out years on that?
Thank you, Mr. Chairman. No, it doesn't affect it at all, this year or out years. There is a cost associated with increasing the protected income limit. And the reason why is because with currently, if you, a person in HCBS or PACE who has income in excess of the protected income limit, that excess income is paid back to the state to help support the cost of their care. And that helps support the Medicaid program. If we raise the protected income limit and take away that client obligation, that's less money coming in to support the Medicaid program. So that's where the cost comes in regarding the protected income limit. But that expenditure has no effect whatsoever on our budget neutrality this year or in out years.
Sarah, thank you. Representative Landwehr has a question for you on this.
Thank you, Mr. Chairman. So I guess I thought the chairman was actually going there. If the conference committee report was only for 1 year, then what happens to the income level in 23 and ongoing years?
Thank you, Representative Landwehr. It would revert back to 150%. Because what we have currently in House Bill 2007, I believe, is a budget proviso. So it's not a statutory change, it's a budget proviso. So that would only last for the fiscal year to which it applies.
Right, and that's one of the things I want to make sure that legislators and others understand, that in our activists out there that work for some of these folks that are interested in this, that it is only good for 1 year. It will take legislative action to go beyond that.
Sarah, I don't see any further questions, so if you'd like to go ahead and proceed.
All right, thank you. So KanCare Kansas, we just had our 1-year anniversary of the program. You can see currently we have a little under 1,200 KanCare Kansas members enrolled. That's about a 100 member increase since February. So the program is kind of solidly beginning to grow. The second main bullet point on this slide, I wanted to make sure the committee was aware. We are working to expand the eligibility criteria for KanCare Kansas. You know, we receive an appropriation for this program, and we have yet to expend it all, in large part because we don't have enough members in KanCare Kansas. And we've received some input from providers that they would like to see more members eligible for this program. So we heard that, and we are in the process of seeking CMS approval to expand some of the eligibility criteria to include a couple other behavioral health diagnoses related to schizophrenia, bipolar disorder, and depressive disorders. If CMS approves this change, we hope to implement it effective April 1st, 2021. And that will expand the universe of potentially eligible KanCare Kansas members. And then the final bullet here, our staff, they've been working to kind of put together a document outlining some of the success stories we've seen with KanCare Kansas. And I've given you kind of a high-level overview of what some of these cases are. We're working on that document, and at some point we hope to distribute it to Bethell committee members. But we did receive a number of, pretty important and kind of touching case studies where we saw how the KanCare program really helped some members achieve their health goals and help them do it in a way that they could financially afford. So we're pretty happy about that. And Marisa, could we move on? Thank you. Okay, an update on the STEPS program. This is the behavioral health pilot program that was included in our 1115 waiver. We're continuing to move forward with this. This pilot program is eligible. It's available for up to 500 eligible KanCare members. The target groups for this pilot are those with certain behavioral health diagnoses and those with IDD, or including those on the IDD wait list. Since February, we've onboarded 3 new staff. So we have 2 benefits specialists and a program manager who are going to be supporting the pilot. The program manual has been drafted, and at this point, we're working on some final details before we roll out the program. And our target go live date remains July 2021. And I would like to applaud all the hard work that our staff has done and the MCOs have done to try and launch this program off the ground. Moving along, Marisa. All right, so some recent highlights. A lot of this information was presented to you in February of 2021, but I thought it was important that we continue to keep track of all these changes that have been made. The big news is the bullet that's underlined on this page, which is that about a week ago, the Secretary of HHS renewed the public health emergency for another 90 days. What this means for Kansas is that we will be eligible for the 6.2% increased FMAP and the 4.34% increased federal financial participation for CHIP through the end of September. If Secretary Becerra chooses to extend the PHE beyond, well, now it's going to be extended into July, then we'll be eligible for that enhanced FMAP through the end of December. So financially, this is excellent news for the state, although I admit it is a strange feeling rooting for a public health emergency to be renewed. But financially, this is a boon for the state. And special authorities, again, a lot of this is just kind of historical information so that everybody's aware of everything that's been done in regards to COVID. The last 2 major bullets on the bottom of the page, that lets you know what's happened since February. So we had a disaster relief state plan amendment that was approved April 1st that will allow pharmacy techs and interns to administer COVID-19 vaccines. We also submitted a disaster relief SPA on April 6th. This is the one I referenced earlier that would allow the state to use 100% federal dollars to pay Medicare rates to providers for COVID-19 vaccine administration. That approval is pending. We hope to receive that approval soon. I would also note that there was a recent executive order issued by Governor Kelly that would expand the list of health providers who are eligible to deliver and administer COVID-19 vaccines. Right now, we're working with CMS to figure out the best way to implement that executive order, so that's in process. Marisa, could we move? Thank you. And slide 13, this is really just some more historical information. No news since February, but this just gives you an idea of the additional special authorities that we've exercised. And on this slide, again, this is all just historical information about the program changes that we have implemented as a direct result of the pandemic. And Marisa, the next 4 slides are screenshots of our KMAP website, which shows all the provider bulletins that we have regarding specific COVID-related issues. So Marisa, if you could kind of flip through those. And then before we move on to an eligibility update, I wanted to highlight some of these analytics and performance metrics. So on slide 20, you can see that our member distribution across the MCOs is remaining pretty constant. United typically has about 37%. Sunflower typically has about 36%. Aetna typically has about 27%. One thing I do want to highlight here, you can see the number of members total that we had at 2020 year end versus year to date as of the end of February in 2021. So you can see that our number of Medicaid members has grown by about 25,000 over those first 2 months. And that is a direct effect of the public health emergency and the requirement that the state not discontinue from Medicaid eligibility any member for a reason other than the member dies, the member moves away from the state, or the member voluntarily requests to be terminated. And so as a result, we're not cycling as many folks off Medicaid, and so our number of members continues to grow. Marisa, can you move along? Thank you. This slide kind of shows you our processed claims versus denied claims for calendar year 2020. You can see that the percentage of claims processed and denied remains pretty consistent across all three MCOs. This is also consistent with what we saw in calendar year in 2019 as well. Marisa, thank you. And then here we focused on just January and February of 2021, the total number of claims versus denied claims. And you can see across the three MCOs, we see very, very similar trends. This is just, yeah, we've settled into a pattern here, and this is all very, very consistent. Moving along, we have some data here comparing calendar year 2019 with calendar year 2020 clean claims processing. What I want to highlight on this slide is that Aetna has made a huge improvement. If you see their results from calendar year 2019 versus calendar year 2020, as a reminder to those folks who are new to the Bethel Committee, Aetna was the new MCO on the block in calendar year 2019, so it's not uncommon to have a little bit of a gear up time frame, but by calendar year 2020, they were marching right along with our longstanding MCOs. And all three MCOs are doing an excellent job in this regard. On this slide, this shows you how many claims are processed between 60 and 90 calendar days. We have a pretty high contract standard here. We expect that the MCOs will process all clean claims within 30 days. 99% of claims would be processed within 60 calendar days, and 100% of all claims processed within 90 calendar days. And you can see that they're all hovering at or very close to 100% in hitting these targets. So they're all doing very well. All right. Then we have some calendar year 2020 information regarding member grievances. We don't have first quarter of 2021 data for you yet because that data is not due until the end of April. So we don't have that yet. You can see as compared to 2019, there were overall fewer member grievances, particularly in the second and third quarters of 2020. We think that's a pretty direct result of COVID, as we had fewer folks seeking services. There was more deferred care going on. So we think that is an anomaly directly tied to COVID. If we could shift, there we go. Member appeals, you'll see the same dip here in calendar year 2020. It's the same trend as we saw with grievances. And again, we think that this is attributable to COVID. And in the top 5 categories of appeals, you'll see that those remain fairly consistent. Thank you, Marisa. Moving on to slide 27. These are provider appeals. And you'll see at the bottom the categories of payment denial appeals. Those are pretty consistent across the MCOs, very similar trends. We'll see in the appeals resolved within 30 and 60 calendar days. We did see a bit of a dip from Aetna in the third quarter of 2020. However, they came right back up above 90% in the fourth quarter of 2020. So again, all three MCOs are performing very well in this regard. Let's see, these are some other metrics that we monitor. Customer Service Center. The reality is that the Customer Service Center can be really the most direct line of contact that a lot of members have with their MCOs. So it's really important to us that their call centers operate effectively. And some key takeaways from this slide is that each MCO fields roughly the same number of calls every year. And the call abandonment rate is very low. That's important to us because we don't want folks to be calling this customer service center, hanging on the line forever, and then just saying, forget it, I hang up. All three MCOs have a very low call abandonment rate, so that's good. Moving along, the customer service center, similar metrics this time for providers. And you'll see a lot of similarities between this slide and the slide before it. Similar trends across all three MCOs, and again, a very low average call abandonment rate, so that's good. I have one more slide for you, and then I will turn it over to Chris Swartz. And this is the MCO profit and loss per NAIC filings. This is for the quarter ended December 31st, 2020. And you can see that the gross profit before income tax was slightly elevated across the MCOs, but otherwise is fairly normal. And Mr. Chairman, if anybody has any questions for me before we turn it over to Chris Swartz, I'd be happy to answer them.
Sarah, thank you very much. And I don't know if this is for you or for Chris, but were you listening whenever I asked the Medicaid Inspector General and then Secretary Norman, and he deferred it to either you or Chris about the capitation payments made on deceased
Yes,
individuals?
absolutely. Yes, Chris and I were both listening, and a lot of the work done in regards to the audit was on the eligibility side, which Chris oversees. So with your indulgence, Mr. Chair, I will pass that question on to Chris for response.
Definitely. Thank you, Sarah.
Mm-hmm.
So, Mr. Chair and members of the committee, good afternoon. I am Chris Swartz, and I'm the Director of Medicaid Operations for KDHE. Thank you for the opportunity to provide updates to your committee today. I will focus my updates on the Medicaid eligibility application updates, the federally facilitated market open enrollment, transition of the Medicaid application eligibility processing, the status of the clearinghouse contract, and of course I would address the audit question that was raised earlier. The status about the eligibility is going to be pretty similar to what I've provided in the past. Thankfully, we've been able to maintain the performance level that we had pre-COVID during the whole COVID period, and we haven't experienced any increases in backlog or even create a backlog. The total number of applications that we have in-house over 45 days is only 144, which is very low. And not surprisingly, it is heavily weighted on the side of the elderly and disabled and long-term care application that require a little bit more time, documents, and verifications before eligibility can be determined. As you can see, the family medical has a total of 7 applications that are over 45 days, and only one of them is an active status, which means we just recently received all of the information we needed to move with processing. So you have to remember that this is at one point in time, and that one application may be done by now, because it comes in a report in the morning, the workers pick whatever moves from a pending to an active status and does that work. So the numbers continue to be very good, and we do not seem to have any issues, keeping up with the workload. Next slide, please. Thank you. Giving you an update on the facilitated market open enrollment, though the original and regular open enrollment at the federal market was ended in December of 2020. And then it was followed by 2 special enrollment periods. On February of 2021, the CMS announced a first special enrollment period, and that would be started from February 15th through May 15th. So that first period of special enrollment was completed in February and will be completed in May. But then in March of 2021, they then announced that there would be a second special enrollment period through August of 2021. So we are right now in the second extension of that open enrollment at the federal level, which basically means that we've been in an open enrollment period at the market since November of 2020, and will continue till August of 2021. We are not seeing any, we don't have any concern with keeping up with those open enrollment period. The numbers that I provided earlier already takes into account all of the additional applications that we're receiving from the market, and we are keeping keeping track with the additional work. So no concerns from our part on being able to perform, even with the second extension. The next slide is giving you an update on the staffing of the KDHE clearinghouse, which will be the portion of the clearinghouse that is operated by state staff, processing elderly, disabled, and long-term care applications. As you can see, we're pretty stagnant here. We're continuing to hire, but we're also losing some staff for a variety of reasons. And so we're still consistently at about a 20%, operating at about a 20% below ideal staffing levels. But we've been able to maintain, production by rearranging and realigning the work that we're doing. So we're still in a pretty good shape there. Looks like we're having the same issues as a lot of the stakeholders that we heard this morning on being able to maintain staffing. So we're all in the same boat here. Next slide, Marisa, please. Then I'll give you an update on the clearinghouse contract. As you know, the Maximus contract ended December 31st of 2020, and a new contractor, Conduent, took over operations of the eligibility clearinghouse for the family medical side of the applications only. We had a pretty aggressive implementation timeline because of the delays that we had experienced with the procurement of the contract because of COVID and delays into the procurement. But we were able to kind of make the transition without any disruption to services to the beneficiaries, and that was the main concern that we had. And things that we kept in mind is we didn't want any impact on the beneficiaries. We had no lack of performance or didn't experience any additional backlog or timeliness in processing the applications. So, the transition didn't have any impact on our processing, didn't have any impact on our beneficiaries, and we were very, thankful for that. And we continue to operate in a very collaborative way with our contractor, which allowed us to actually perform a pretty smooth transition. So unless there are any questions with this report, I will move to the audit issue.
Chris, thank you. We do have at least one. Senator Fagg.
Thank you, Mr. Chairman. On slide 34, it talked about 20% vacancies. What's the historic trend line to that? Is that high or low?
Well, I do not have a lot of history on that because it's been pretty consistent ever since the work has been moved from a contractor to the state staff, and that occurred in January of 2020. So since January of 2020, we've been trying to kind of build up our staff to the full level that was, allowed and approved and funded by the legislature of 313 positions. So consistently for the last year, we've been at about 20% lower than the ideal staffing. And I don't have history before that because the state staff wasn't doing the work. It was contracted out to Maximus.
Representative Concanon.
Thank you, Mr. Chair. Thank you, Chris, for the report and for all the work that's been done in this transition, bringing the enrollment back in-house. Kind of in hindsight, I'm just wondering if you could identify why it is so successful, what we're doing now, and looking back at what had gone wrong.
Well, I think we learned from our first experience, and we structured the contract to have some very specific service level agreements that we had. We abandoned some that made no sense, and we added some that really made sense into improving how we were performing. I think there is also, we also learned how to handle the contractor, how to monitor the activities of the contractor, and how to work side by side by them so that we can immediately identify any issues that could become a problem and actually address them for a variety of things, either relaxing some certain processes that we have in-house that are just discretionary, or through redirecting some of their work. So we are a little more involved into their day-to-day operations and having basically our nose into their business and making sure that there are no lapses in performing and no lapse in their understanding of policies. We also took over, I don't know if you remember this as Senator Covenant, but we took over the training. And I think our training program now, where we have actually a very specific training program and test at the end of the program, make sure that we have workers that we're not depending on the contractor to do the training, and we kind of control the quality and the knowledge of the workers for our training program. So I think that was a big component of that too.
Okay, thank you. And thanks for all this attention to detail, and we appreciate the fresh start and all the improvement. Thanks, Mr. Chairman.
Chris, I don't see any further questions on your slides. Would you like to go back to the Inspector General's question?
Absolutely. Thank you, Mr. Chair. We've done a lot of things after this audit. So this audit was an eye-opener for us and allowed us to put a number of things in place and correct certain things that will ensure that in the future it doesn't happen. But let me tell you basically what happened there. We were operating in a fee-for-service business for a long time, and we then shifted to managed care, which is a total different delivery system. In a fee-for-service system, once the person dies, basically, there is no claims coming through. And there's no access to services and no demand for payment of the services occur. So our systems were built to contain that information about the date of death into the eligibility system, which now is KEYS. So that information was in the eligibility system. But when we closed the case into KEYS, that date of death wasn't passed to the claim payments and the capitated payment system, which is the same system. In the instance of claim payments, it didn't make any difference because no claims were coming through. And that's why we never had any audit findings about paying claims after the date of death of a beneficiary. However, in a managed care system, unless the other system knows that there is a date of death and it's not updated into that system, the system continues to be paying capitated payments. Most of the time, we're not aware of the date of death until, at a later date. And so there's a little bit of discrepancies. The person may have died, a couple of months ago. Then we do a data match with the various things, and now it comes up with on a data match, and we close the case, and we enter the date of death. By not entering the date of death, it didn't allow the capitated payment system to actually do its job, which is the minute there is a date of death entered, not only it closes the case, but it also goes back and recalculates if any payments, capitated payments, were made and recoups those payments. So once we identified this discrepancy, we have now aligned the communication of the information between the two systems. None of them were at fault. It's just that we were not passing the information the way we should have passed it. Once the audit alerted us of this, then we went by and manually did a sweep on all of those that came to the surface through the audit, as well as doing another pass through both of the systems to align them. So now that the Medicaid MMIS system is aware that there is a date of death entered, which we've done, and in some instances manually because the data was old, the money has been recouped basically from the MCO, except for the AmeriGroup MCO was no longer into the program, and therefore we have nothing to recoup against. And the Medicaid director, Sarah Furtick, is in communication and conversation with the merit group and providing them with data to show that this money is owed back to the state. So I would say that 90% or more of the money that was identified as part of the audit, as well as other cases that came up when we did the big sweep between the two systems, has been recouped at this point in time. And we're continuing to pursue recoupments.
Chris, thank you for that explanation. Just to clarify, you have been able to fix that going forward so that it doesn't happen anymore. Yes. Is that correct? Okay, thank you.
Correct.
And Chris, I do not see any further questions from anybody in the committee, so thank you again for your update. And committee, we will now turn to our next section, which is our KDADS update with Secretary Howard. Secretary, are you with us?
I am. Thank you, Mr. Chairman. Can you hear me okay?
I can. Thank you, and welcome to our committee.
Very good. Thanks for the chance to be here today. I'll kick this off a little bit as Secretary Norman did before turning it over to my two deputy secretaries and commissioners to get into some specific detail. And I was reflecting a little bit the last few days about kind of where we are, as we think about the context of the pandemic, and then looking ahead. Just as Secretary Norman reported, I think we've just been very pleased over the last couple of months to really see, that huge decline in terms of the number of cases in really targeted places with regard to our state hospitals and our nursing facilities. For example, this week, no new cases of COVID at any of our state hospitals, and still fairly small numbers at nursing facilities, and yet that need to remain vigilant as those new clusters have kind of come up. The information we've learned from the episode, for example, in Wichita that Lee Norman talked about, where a staff person brought the virus in, vaccinated individuals did not become sick, but did become infected. So I think for me, obvious, continued vigilance, continued focus, but I think also that ability to, more fully look ahead to the work that's in front of us. Not that we've ever looked away from it, but, we have, I think some really tremendous opportunities within Kansas right now, and an awful lot of that is due to, I think, the work and vision of many of you around this committee, as well as some of the important items that have been implemented or recommended from both a policy and a budgetary perspective. So I really wanted to make just a few comments on some of the areas where I think it's critical that my team and I spend focused time on now and over the course of the next year, that you'll be hearing more detail on, in meetings to come. Some of these are not new, but some are really a result of legislative activity yet this session. I think one of the most important areas where it's important that we spend some body of work relates to the waiting list issues. You've heard this from the advocates for a number of years. And we focus a lot on IDD because the numbers for the waiting lists are so large. But I think it's also important that we don't leave out, for example, the physical disability waiver. So one of the bodies of work that it's important that we focus on, and you heard a little bit about this in the update from Deputy Secretary DeBoer, may hear a bit more from Amy yet this afternoon, is really doing that deeper dive analysis of those waiting lists. Understanding more the individuals on those waiting lists, what their service needs are, when they need those services, and also being able to stretch that into what other options might there be. We've been functioning for decades in Kansas with really the same models and the same waiver models. It's time to think differently. And frankly, some of the additional focus at the federal level on HCBS, some of the recommendations that may come out federally in legislation yet to come, I think makes it really incumbent that we make significant progress on this and really have some policy options to share with all of you in the coming months as we think about our waiting list. So that's a really important body of work. A second body of work, when we think about the mental health system in our state, really has to do with the work this legislature did and some of you around the table who really showed some leadership on the topic of the certified community behavioral health clinics. I can't overstate the opportunity this is for transformation in Kansas and really enhancements and strengthening of our mental health system. We've got some key body of work that's going to be important for us to do in KDADS, and we're committed to doing that work. A significant part of that is the work around certifying CCBHCs over the course of this upcoming year, as those would come on board more formally towards the end of the next fiscal year. A third piece of work that I think about is building back the capacity at our state hospitals and finally lifting the moratorium at Osawatomie State Hospital. When I talked about the lower number of COVID cases at both of our state, at all of our state hospitals, but particularly at our state psychiatric hospitals, that means at Larned that we can begin that work of building back to their full capacity in the psychiatric services program and in the forensics program. So we're really excited about that. And we've got really, really active work going on right now that Scott and Andy will talk more about relating to the development of regional beds and how that intersects with the ability to lift the moratorium in this coming fiscal year. Long overdue. We will get there. That will be done in the coming months. I also wanted to mention and just maybe go back a little bit to a conversation earlier this morning relating to the crisis services and the mobile crisis. I couldn't agree with Representative Landwehr more how critical it is in terms of how the state responds to the 988 opportunity and how important it is to have resources in play, both for what I think of as the dispatch part, the folks actually answering those phone calls, but also the ability to actually respond. And I might, just to make sure this committee's up to speed, just remind folks of some activity that we were able to begin really with my DCF hat, but it's really been a partnership of DCF and KDADS, where we've been able to begin some of that work on mobile crisis through some one-time funding in DCF related to mobile youth crisis, what we call the Kansas Family Crisis Response Services. And in February, we awarded a contract to Beacon Health Options for Kansas Family Crisis Response Services. These services will be operational by September 1st. And this really provides both crisis helpline and mobile response services for all youth in Kansas, not just youth in foster care, but all youth 0 to 18 and any child in foster care up to age 21. And this includes, not just the phone support, but the ability to have mobile crisis response wherever that child is. And in the case of really emergent issues, that could be within 60 minutes. I mean, that's really the expectation within the contract. If it's not as emergent, it might go into the next day. But again, our contractor Beacon, I mean, they're working hard. I would thank our partners at KDHE, the MCOs, other community-based partners like the community mental health centers as we work hard to stand this up. I think really, really critical response. And based on the dialogue this morning, I also wanted to say this also will serve youth with IDD who are experiencing a crisis. So they're not left out of this. So again, I wanted to mention that. And also another recent contract award that we did at KDADS to Family Service and Guidance Center in Topeka to provide immediate crisis services through for up to a maximum of 28 days for youth age 5 to 17 in a therapeutic environment. So if you think about the way we've resourced adult crisis supports across the state through the various crisis centers, this is the first time we've funded a youth crisis center like this. And Family Service and Guidance, we announced that last month. So again, a couple pieces in that wall of crisis supports, but as Representative Landwehr spoke earlier, there's still work to be done with regard to fully being able to implement the promise of 988 in Kansas. So again, very, very excited about that. I think another area where we continue to place a lot of focus has to do with what I would think of as really ensuring folks have opportunity to live their best life in the community. That includes the final settings work you've been hearing about for so long. That includes the reinvigoration now of the money follows the person. And it also includes some work that we're doing around nursing facilities for mental health and services and supports to individuals in those facilities. So a lot of work that I think are just such core foundational work about building strong systems. So again, more to come on each of those, some today, but on many of these in meetings to come. I think these will be some of the most critical areas to talk with you about in your meetings over the course of the next year. Intertwined with this, I might comment just for a moment on a piece that was in Director Furtick's slide in talking about the enhanced FMAP under the American Rescue Act related to the home and community-based services programs. Unlike the enhanced FMAP across the Medicaid program as a whole, this enhanced FMAP of 10% for 1 year can't be supplanted. It really, we have to, in essence, reinvest that to expand and strengthen the capacity of HCBS, home health PACE, and supports and services like that. We'll be talking more with you about that in the months to come. We are still waiting on guidance from CMS. We don't know yet how much time we'll have to spend the resources. We don't know yet what those guardrails are on how those can be spent, but know that many of the things you heard about this morning that this committee has talked about that really have to do with, looking at workforce issues, perhaps technology options, how we just strengthen capacity, fill some gaps in those systems will certainly be on the table as we begin kind of formal work on what those options might look like there. I think the last thing I might say is just a couple of responses to a question this morning, I think from Representative Ballard related to the caseload presentation. I just wanted to maybe clarify a couple of pieces there. First on TANF, as Representative Ballard indicated, we do receive a block grant for temporary assistance for needy families. It's about $102 million a year. Of that $102 million, about $11 million of that goes to cash assistance. It's the cash assistance part of that is the entitlement program that's included within consensus caseload. So the remainder of those dollars go to other supports and services. A fair amount of that is invested, about 40% of that actually does support part of the foster care program. Another significant portion of that goes to a number of youth and family service grants And some of those funds also support the DCF field staff who do eligibility for the program. So, I mean, that was one question from the caseload. And then I think the second one had to do with the St. Francis case management entity and their repayment and how that intersected with caseloads. We did come to an agreement with St. Francis Ministries for them to repay some funding that they had not expended over the last couple of years in the foster care grants, about $9 million. That $9 million in returned funds was then taken into account in terms of the state fund needs in caseload. So we did not retain that to spend that on other things. That went right back into the consensus caseload process. So I think I'll stop with that, Mr. Chairman. I'm happy to respond to any questions now or after the rest of my team has presented, whatever your preference.
Secretary, thank you. And if it's okay with you, it looks like Representative Ballard does have a question for you. And if anybody else has any for you, we'll go ahead and take those as well. Representative Ballard.
Thank you, Mr. Chairman. Secretary, I just want to follow up on the TANF. At one point, and I can't remember, I asked if we could have a list of the funding that we are actually spending TANF for. And I don't remember if we received that or if we formally asked for it. Do you remember?
I do, Representative. You might recall that we did a presentation in Social Service Budget Committee on TANF and detailed out a chart and then a listing of each expenditure item. I'd be happy to share that with the staff, to share with this full committee as well. We might update that with the recent caseload estimate. But that would provide a summary of how that $102 million is spent, and then a little bit of detail on each program.
Thank you. That would be very helpful. I think most people in this room have heard me on TANF already. And again, it's because of that $102 million that we actually, when we initially got that, it was for 5 years, and that would have been the cash assistance and everything else. And over time, we have gone from 5 years to 2 years, and there's been thousands of people taking off of the rolls. And, it does cause me a little bit of heartburn, not a whole lot anymore. I mean, it used to be a whole lot, now it's a little bit. But with that issue, to go from 5 years to 2, and cash assistance, where a lot of that would have been with child care and a whole combination of things, and yet, even though we have reduced it, we continue to get 5 years worth of money because that's how it started, and it's still there. And we have used that as a catch-all in many ways. Whenever we've needed money, we have looked at the 4 guidelines, and then we have just put them under which one of those that makes it legitimate to use that money. So that's my real reason for it, because actually I would like an audit study to look at how we have spent all of those funds and what has happened to all of those people that were on it. Since this is a lifetime, you only had 5 years to be on it. Now it's only 2 years unless we decide you get to stay on it further. And that just doesn't seem effective to me. So that's the reason why that list becomes increasingly important for me, because I continue to get numerous emails centered around that.
Yeah, thank you, Representative. It continues to cause me heartburn, to be honest, and continuing to have some concerns about the most vulnerable families in Kansas, especially during a pandemic. And frankly, especially as we have, reports and studies, for example, from some of our university partners that can make some connections between the loss of TANF assistance and entry into foster care. So again, I always thank you for bringing that topic up. I think it continues to be an important policy conversation.
And thank you, and I'll look forward to receiving that list. Thank you very much. Thank you, Mr. Chairman.
Secretary, I do not see any further questions from the committee, so thank you for your update. And now we turn to Janice DeBoer. Janice, welcome back.
Thank you, Mr. Chairman and members of the committee. I am Janice DeBoer. We can go to the next slide. As I mentioned earlier this morning, so I will be quick. Of the 22 facilities that were in receivership in the last 2 years, we have one remaining on the market for sale. We do have a potential buyer, but have not heard anything permanent yet on that opportunity. So, and with that said, Scott Bruner has indicated via text that he will answer the question that was posed earlier during his discussion. So next slide. I'll just simply note that the nursing facility program does include oversight of Medicaid enrollment, change of ownership, reimbursement rates, auditing, which we talked about earlier this morning, the quality care assessment, which is directly linked to the provider tax, the CMS enforcement, the ventilator program, PEAK, which we didn't talk about this morning, but I can do that at our next meeting, and then the nursing facility regulations. So that is what the program side of the nursing facility the nursing facility program is responsible for, compared to Scott's oversight that you will hear later this afternoon. So I think there might be one more slide, Scott. This doesn't change much quarter to quarter, and it didn't change much since February, but we want to continue to share the information with you anyway, as it will allow you to keep an eye on the number of nursing facilities across the state post-COVID. So with that, I think that is my last slide, and I'll hand it over to Commissioner Amy Penrod. Thank you.
Janice, thank you. Amy?
Good afternoon, committee, Mr. Chairman. My name is Amy Penrod. I'm the Commissioner for the Aging and Disability Community Services and Programs Commission within KDADS. And my presentation starts on slide 8, which is before you here. This is our waiver enrollment as of March of 2021. As you can see, the intellectual and developmental disabled disabilities waiver is serving a little over 9,000 individuals currently, and the wait list is at 4,542. The physical disability waiver is serving 5,966 individuals with a wait list of 2,168. And let's see, also, I will point out the number of individuals enrolled as of the end of March was 725 for the brain injury waiver. And I believe that is one of the statistics that KDADS has been asked to continue to report to the Bethell Oversight Committee. So this is kind of standard information for you. Next slide, please. In addition to the KDADS day-to-day management of the 7 home and community-based service waivers, we are choosing to focus on the following initiatives during calendar year 2021. There is a lot of work to be done with the home and community-based settings final rule and compliance with that, and assisting our provider networks to come into compliance with that. So we are placing a lot of focus there. As has been discussed several times already today, reinstating the Money Follows the Person program. And we have been working with a small stakeholder group up to this point, and really trying to come up with a design overview for that program, as well as working towards getting the MFP steering committee reformed to help us in program design and carrying out the re-implementation of that program. We also are working on waiver amendments, and those are all based on stakeholder feedback. There has been a lot of discussion about supported employment and how we can enhance our offerings with supported employment. Targeted case management is also a system that needs some attention. There are some not only issues that we need to address for CMS, but also just for the smooth operation and kind of to enhance the provider experience there and to build our network. Finally, the last two items are brain injury waiver policies. And again, you've heard about those today, some, and I'll provide a little bit more detail in another page or two in my presentation. And then finally, as we work into the summer here, the autism and severe emotional disturbance waivers are going to be renewing or up for renewal in calendar year 22. And so we will be beginning our renewal process, which includes a lot of public comment and hearings and some of the work to make potential updates to those waivers. Next slide, please. Thank you. Okay, so some information on the brain injury waiver. I believe I've provided this in the previous committee, but just wanted to add it for a refresher. This is information about the timeline of the transformation of the TBI waiver into the BI waiver. So from when the legislature directed the expansion of the TBI waiver eligibility to include acquired brain injury, that happened in May of 2018. And we have been steadily working towards the full implementation, which was completed in November of 2019. We are, let's see, go ahead and next slide, please. A part of the information, as I referred to just a moment ago, that we are requested to provide to the committee on a regular basis via House Bill 2007. These two data points are part of that list. We will be adding the others as we go along here, but these were readily available for you today. Again, this is showing the number of unduplicated individuals served on the brain injury waiver over the years and year to date. So our approved waiver was funded for an unduplicated number of 723 individuals. And as of the end of March, I believe we were at 820 individuals served for this fiscal year. Also, we've included the brain injury participants by length of stay. And as you can see from this chart, 518 have been on the waiver for 2 years or less. 85 have been on the waiver between 2 and 4 years, and 122 have been on the waiver for over 4 years. And again, just referring back to the previous information, one of the other data points is that there are currently 725 individuals enrolled in the program currently. Next slide, please. So another update for you on where we're at with our policy work group and the review of our processes and procedures as it comes to waitlist or brain injury waiver management and avoidance of a waitlist. We have had a couple of meetings with our work group. They are very engaged and we're grateful for their engagement. We are looking at the program's key areas, which are eligibility, service delivery, and transition. Our current focus, our heavy focus at this moment is on the policy work related to transition planning for individuals on the waiver and establishing criteria and processes for a review committee to evaluate participants' progress on the waiver. So right now, we feel like those are the top priority items for good waiver management, and our work group is very much interested and invested in helping us with that review.
Amy, before you proceed, we have a question from Representative Carpenter on the brain injury waiver.
Sure.
Amy, slide 11, you show 122 people that have been on the brain injury wait list. So, or on the, by length of stay over 4 years. So how does that work? Shouldn't we take those folks are they still being rehabilitated? From what I know of the brain injury waiver, if people are on there more than 2 years, you've kind of exhausted the rehabilitation part of it, and it's time to start thinking about other alternatives. So are these folks, these 122 folks, still able to be rehabilitated, or should they be moved to a nursing home or a skilled nursing facility? Could you enlighten me on that, please?
Sure, and I think it really varies from case to case, and of course, it's really difficult with brain injuries to generalize the extent to which someone can be rehabilitated. It will vary from individual to individual, and the length of time that it takes to complete that rehabilitation does vary quite extensively. I think there has been we've done some review of the length of stay on our waivers, and individuals tend to, as they grow in time on the waiver, tend to require more of maintenance type services. And so that is part of what we are reviewing with our group and with our data, is to determine as we come to, kind of a general threshold where an individual, based on a progress review, like the committee we're talking about, reviewing a case, if they still have needs, but perhaps their needs are not as great to be qualified for the BI waiver, that perhaps there are other services that would be best suited. And so as we go through our review, we are really looking at what the options are for transition from this waiver. Some individuals with brain injuries will continue to need some assistance going forward. It isn't a all or nothing. And our ability as a state to provide appropriate services for them as they transition off of this waiver will be key. So that is part of our review process.
So as a follow-up with that, because we have a wait list on the ID and PD, does that have anything to do with that?
To an extent, there would be some potential that an individual on the BI waiver could qualify for the PD waiver. And of course, there's always the concern that while we have a wait list, we take that very seriously with the individuals that are waiting for services, and how those transitions might work from one waiver to the next waiver. I think there is also some discussion and thought about the services that are available on some of our other waivers. There are some cognitive and behavioral therapy services available on the brain injury waiver that are not available on the physical disability waiver. And some of those services tend to be frequently cited as continuing needs. So as we're looking at length of stay on the brain injury waiver, the services that are most used on the brain injury waiver, we also will need to evaluate the types of services that are available for individuals who are transitioning.
Well, thank you very much. What I would like to see is that these folks aren't on the brain injury waiver just because there are no services available for them on the ID and DD waiver because of the wait list. And so if that's the case, we could actually add this 122 to the ID and DD wait list. So anyway, thank you for that.
You bet.
Representative Ballard.
Thank you, Mr. Chairman. I would just like to comment on what Representative Carpenter has said, that, what we have always been under the assumption is that as quickly as we can get an individual on this waiver, the quicker they're likely to be rehabilitated and they can go on with their lives. They get off of it and we make room for other people to come on. And so that's where we're going. So that's why I think it was a panic in a way by the time we had acquired to this list as well. And then to see other people staying on 3 and 4 years and everything else. And so that's like, they weren't moving quickly to get off, and other people, and we're going to end up with a waiting list again. So I guess I'd have to say I would agree with Representative Carpenter is that I hope we're not keeping them on because there's no other place for them to go. And that makes me a little bit nervous too, because, you know, we didn't used to have a physical disability waiver. We didn't have a waiting list. I mean, not the waiver. We didn't have a waiting list. Now we have a waiting list for physical disability. So it seems like our list, or where we didn't have it, we now have another list that's going on, which means we have more people, and for some reason, we're not able to move them off of that list. So that would be my concern as well, that we don't want to start new lists because we're having a hard time getting rid of some of those lists that could be more beneficial to people. The other question I would like to add, even though I was talking about TANF earlier, was the moratorium being lifted at Osawatomie. You know, we discussed this in social services in 2019, and part of discussing in 2019 with Secretary Howard, we asked at that time if we could get a comprehensive plan for how we would lift that moratorium, and we would get that report in 2020 in January, and we did. She delivered it in 2020 as well, and at that time said that looking at their plans and what all they needed to do, they would be able to lift this in May of 2021. Well, little did any of us know we would have COVID-19 affect us, and we would end up leaving in March, and everything else occurred. So as a result of that, and being able to find available bed space and everything else, you know, we heard that it would be January, maybe December at the earliest, that we would be able to lift that moratorium. And everything else was put back, not just on lifting the moratorium, but lots of other things. What we ended up doing about 3 weeks ago is passing some legislation that indicated that this space would be opened up, I believe if I have it correctly, in October. My question would be for the secretary or whoever wishes to answer this, are we able to find that available bed space that we really need? Because, you know, it was in social services that we were the ones that said we wanted to lift this moratorium, and we've been following it logically through everything, and the secretary has done it. And now there's this get it done sooner. So I want to know, are we able to really get it done sooner? Even though, there's something out there in the bill that says, yes, you will do it. But is it feasible to expect that we will be able to do that when we've been monitoring this on the moratorium? And I offered the proviso in appropriations. That's why I'm really hung up on this one, because we were the ones that pushed through, let's do it, when other people are just leaving it alone. And now it's like you're going to push it ahead. I just want to know, is it possible, and will that work for the people in this state that really need to have mental health services?
Representative Ballard, if we might, Deputy Secretary Bruner is going to have some slides specifically about the moratorium. If we could talk about this when we get to those, we're happy to talk a bit more about the impact of an October 1st date on our plan, right, if that's all right with you, Representative.
It's fine with me. I just didn't know it. Were we going to, or were we just going to go over it? I just wanted to. Thank you, Mr.
Perfect.
Chairman.
Thank you.
Amy, I do not see any further questions, so if you want to go ahead and proceed.
Sure. Let's move on to slide 13. And this is just a brief refresher. I know some of you may be new. So the home and community-based services final settings rule, this just kind of gives you a snapshot of what it is we're talking about here. The home and community-based settings final rule aims to ensure that individuals receiving long-term services and supports through home and community-based services have access to benefits of community living and the opportunity to receive services in the most integrated settings possible. The final rule does apply to all settings where HCBS services are delivered. And this does include non-residential settings such as adult day service centers, as well as residential settings like assisted living facilities. And I do apologize, that last line there, the home and community-based settings are required to come into compliance by March 17th of 2023. And I apologize, I think I got fingered my presentation there, but we do actually have one extra year than what is noted on this slide. And so if we can move to the next slide. And this gives you a little bit of information about the process that my team has been taking since September of 2019. We have been working with providers to complete self-assessments, provider self-assessments of each site that provides home and community-based services. Each of those self-assessments has been reviewed by a team that works for KDADS, as well as a university contractor with WSU. In reviewing those self-assessments, there are some sites and some settings that do have a little bit of work to do in order to come into compliance with the home and community-based settings final rule. A lot of that work centers around policies and procedures. There are some settings that do have a few more hoops to jump through because of where they're located, whether they're on the grounds of a another setting that features institutional features or has the potential to isolate home and community-based service participants, and they will receive what we're calling a heightened scrutiny assessment. What I think is really important to note here is that we've had some amazing participation from our HCBS providers. Of the 2,800 sites that submitted and providers that submitted self-assessments, over 1,500 have already started remediation and as a result of the feedback that they've received from our desk review. And while it is a bit of a slow process, I am pleased that according on this slide, we have we have 368 settings have been deemed compliant. In actuality, as of a couple of days ago, we were already over 400. So it does really grow day to day, hour by hour. We have additional settings coming into compliance. So we're very happy with the participation and engagement that we've received from our home and community-based service providers. We can go to the next slide, please. And then I just want to take this opportunity, because I know we have a lot of providers that listen in. We are having some additional opportunities or upcoming opportunities for providers to participate in some question and answer sessions regarding final settings rule. Each of the 3 sessions that we have listed here are learning opportunities, will allow the providers to ask questions and receive answers and guidance on actions needed to reach compliance within the HCBS final settings rule. And the goal will be to provide as much of that information in real time. So the hope is that folks can ask their questions during these sessions and receive immediate answers. And I did include the link for providers and other interested parties to go to our final rule website, which is www.communityconnectionsks.org. Next slide, please. Next, I wanted to talk to you, I'll give you another update about our administrative case management program. This program provides eligibility and enrollment assistance to individuals who are functionally eligible for the brain injury waiver, the frail elderly waiver, the physical disability waiver, and PACE. This program launched statewide on May 1st of 2020. And as you can see from the numbers, you can tell that the programmatic numbers have grown significantly since the beginning and continue to grow month over month. This program is administered by the Aging and Disability Resource Centers and has been very successful since its launch in May. Next slide, please. And then to wrap up my section here, wanted to give you the PACE enrollment for the 3 PACE providers. Again, Ascension via Christie Health in the Wichita area is at 261. Midland Care, which has sites in Northeast Kansas, is at 374. And then Bluestem Communities, which is in kind of South Central, would be at 93. So we have a total enrollment of 728 individuals currently in the PACE program. And then my final slide is just a reminder of the service areas for each of those providers. And I will stand for questions.
Amy, thank you very much. I do not see any further questions from any members of the committee. So we will now turn to Andrew Brown, Behavioral Health Services Commissioner. Andrew, welcome to the committee. Andrew, are you with us? Andrew is not here. Okay.
He's here.
Scott?
I think he's just on mute. Andy, are you on mute? I see you, but I don't hear you. Unmute at the bottom there, Andy. There you go.
You know?
Andy, are you there?
Yeah, this is Andy Brown with KDADS.
Okay. Yeah, we can hear you now. Thank you, Andy. Welcome to the committee.
Okay. Well, thank you for having me. We'll go pretty quick here. We have been tracking our PRTF information. So our current MCO wait list as of April 8th was up a little bit from December. There are 120 individual kids compared to 108 in December. Of those 120, 28 were in foster care, which is up fairly significantly from 14 in December. Our current number of PRTF licensed beds is 412 in the system of care. That's up from 386 in December. Approximately 100 of those beds are not being used by providers. Their current census remains around 300 total. The main problem there seems to be finding workforce for those beds. And we currently have, out of those 300 that are in census, about 74 of those are foster care youth. The PRTF regs are still being reviewed for fiscal impact and to determine if a hearing is required. KDADS has hired a new Children's Community Inpatient Program Manager. She started a couple of weeks ago. We've been meeting with the MCOs and DCF weekly to review our individual cases on the wait list. That work continues with the MCO care coordination in order to facilitate community-based services. And our current average wait time for PRTF admissions is 19 days. And this is down significantly from about 185 days of wait time in July of 2018. Next slide. So KDADS has issued an RFP to receive bids on providing the 8 children's psychiatric hospital beds in Hayes that was passed last year in the legislature. That event was posted last month. We've received questions. KDADS has provided responses to those questions. Proposals have been turned in. We've completed reviews of the proposals. And we're now working with the Department of Administration to negotiate with the selected bidder. At this point, we anticipate being able to award a contract in May. Next slide. So if there's any questions, I can take those.
Thank you. We do have one from Representative Carpenter.
Andy, thank you for being here. So just backing up there, so we have 100 PRTF beds that are not being used by providers, and we have a wait list of 120?
That's correct.
So, and they can't find employees, I guess, to work those facilities?
Yeah, that seems to be the largest of the barriers at the moment.
So we've done all this work to get these bed totals up, and we can't find employees to work in those facilities to help these folks and eliminate our wait list.
Yeah, we're getting close. I feel like, we need to do a little bit of strategy around what we can do to incentivize employment. But a lot of those beds just came online since December. So for the most part, they've only been part of the new system now for the last 3 months or so. And we are, like I said, trying to get them staffed up. And I think our providers are doing a good job of working towards that goal. But I wanted to be clear that the beds are available. We just haven't been able to get them staffed yet.
Wow, thank you.
Andy, we have a question from Representative Landwehr.
Thank you, Mr. Chairman. So Andy, when we're talking about these beds, how many, or is this a combination of the adult and the youth beds, or are these just youth?
Those are just youth beds. The PRTF beds are just for youth, and there are under 21 psychiatric residential treatment facilities.
Okay, the 100 beds that we're not able to utilize because of lack of staff, if I understand the numbers right, how many of those are urban? How many of those are rural, or are they a combination thereof?
They're a combination thereof, but the majority of them are urban in the Kansas City area.
And what level of qualification for an employee are we looking for?
It actually varies to some degree. So the different facilities have different vacancies right now that they're trying to fill for their teams. But I think the largest gap to fill is on the low end, where we're looking for folks that are providing sort of mental health tech level services.
When you say mental health tech services, what is the educational requirement for that under BSRB? Is that where that's at, or somewhere else?
No, it's not with BSRB. I don't believe it's essentially a position that works and is trained by the PRTF. There's no, I don't think there's a college level requirement for it. They can be hired and work for the PRTF. They're supervised by the nurses and the medical staff.
All right, thank you, Andy.
Representative Ballard.
Thank you, Mr. Chairman. Okay, I'll take a bite of this apple. Let me get to it. What's the hourly rate for whatever this position, if it's the mental health tech or whatever? Is it we're not paying enough to recruit these people, or they are just not available?
Well, like I said, I think if we can work on how to incentivize employment, that may help fill the gap. But each of the nonprofits that runs these PRTFs have different cost rates. And so one of the issues is just they're trying to make sure that they can hire the staff and get that adjusted into their cost rate for Medicaid. So KDADS doesn't actually set salary for any of these positions.
Well, if we don't set salaries, and I am looking for employment, and I want to see how much I may be getting paid an hour, there'll be nothing out there for me to know how much I'm going to get an hour or how much I get a week. Am I paid every 2 weeks? Are we not giving any kind of, when you say incentivize, I'm trying to think, what is incentivize? I mean, the position is open, we have this, it's 8 hours a day, or they're going to work 12 hours a shift or whatever. I guess I can't understand if we have the beds and they just came online.
Yep.
And they're at various levels. We have to have levels that we are paying these individuals. Am I correct?
Well, the PRTFs, I'm sure, post the positions with a salary or at least a range.
Thank you, Mr. Chairman.
Andy, thank you. And Representative Ballard, I don't know if maybe see if I understand your question. I might be able to answer possibly. Because the state doesn't know what those hourly rates are, is because it's contracted with a private company. So the private company would have that information available to the employees, but the state might not. Is that correct, Andy?
Yeah, and we don't actually contract with them either. The PRTFs are Medicaid providers. So they work for the 3 MCOs and do reimbursement through the MCOs.
Okay. Thank you, Mr. Chairman. Well, that explains it a little bit more to me. But when we say that we have the beds, but we can't find employers, and we don't know what the qualifications are or how much they're getting paid, then we only have part of the story. So I guess if we want this information, do we get it from the MCOs?
No, I mean, we meet with the PRTFs on a monthly basis, and we can get it directly from the PRTFs. But it's not data I've collected from them yet.
Okay. Thank you, Mr. Chairman.
And Andy, we have one more follow-up question from Representative Landwehr.
Thank you. And I think Representative Ballard just kind of touched on this, is that, Andy, if you can check with where the PTRFs to give us a range of what we're dealing with. And it might also be something, and when the MCOs come up here in a little bit, maybe they've got some data that they can share with us so that we can see where our shortage is and if there's anything that we can assist with this, because it's kind of sad to have 100 beds sitting out there because we can't staff them. Thank you, Mr. Chairman.
I agree. We will be working with the MCOs to try and address the issue as we move forward. I just wanted to be clear that like each of the 10 PRTFs has a different rate, and that's adjusted through our cost-based rate adjustments.
Andy, thank you very much. Scott Bruner, are you next?
I am, Mr. Chairman.
Okay, Scott, hey, thank you and welcome to the committee.
Thanks for the opportunity. My name is Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities, and I'll walk you through the next section. I did ask our Commissioner for Survey and Certification to take the first few slides about adult care homes, so I'll turn it over to Lacey Hunter and then come back and talk to you about state hospitals here in a few minutes.
Thank you, Scott. Lacey?
So, Lacey, go ahead.
Thank you. Good afternoon, committee. Thank you for having me. Happy to be here. This first slide here, slide 23, talks about the antipsychotic drug use and the partnership that CMS has created for some time now, since 2011, and where we stand as a state. This slide has not been updated since our committee hearing in February. They have not seen a new quarter worth of data to update this slide since then. But we did go ahead and include it as it was included in the request. Next slide, please. This slide, we discuss what we're currently doing as far as survey activity for the adult care homes. We did complete infection control survey work in all adult care homes as of September 23rd, 2020. Next, we kind of talk about the current survey activity in nursing facilities. And at this time, that survey activity is still being a little bit restricted by CMS, but they are allowing for complaint investigations that are at the IJ, non-IJ high, or non-IJ medium level. Special focus facility recertification surveys. Recertifications for facilities who have had a 15-month or greater interval since their last standard or recertification survey. And lastly, on-site revisits for any type of survey that was completed after June 1st. Next slide. This slide discusses what we're doing in what we kind of call the state licensed only adult care homes. And that survey work currently is the annual licensure survey work, the same type of complaint work with that same triage levels there as the same as the nursing facilities, on-site revisits, and then initial licensure surveys for those facilities that are opening up. Next slide. This slide is a little bit new. It is something that we typically pre-COVID included in our Bethel presentation, and I think it was replaced with some of the COVID survey efforts and a little bit more detail on the infection control survey work for, I think, the better part of a year, if not a little bit longer. But we have brought it back into our presentation, and what we have done here is we've captured where we're currently sitting as of December 30th, 2020 with our survey intervals for those different types of adult care homes. The information over to the right there then includes both the state statute as well as the federal performance standard for survey interval requirements for our agency. Next slide. On this slide, we discussed what we're doing as far as our efforts with collaborating with KDHE and BCG for vaccinations. We did host a webinar back in March, I believe March 26th, with both KDHE and BCG, where we discussed the ongoing efforts for facilities vaccination for people such as new employees or residents who maybe have chosen in the past not to get vaccinated but have changed their mind, new admissions who have not been vaccinated, and kind of what those options should look like as facilities move forward with those vaccinations. We also continue to provide outreach and contact for KDHE and BCG to those adult care homes as they request and as they are needing. Next slide. The last thing I was going to talk about here is CMS as well as KDADS have updated their visitation guidance. The guidelines that CMS updated happened on March 10th, and then KDADS quickly issued an update to our visitation guidance on March 15th. And here I have put some of the key changes from prior guidance issued in 2020. Those being that indoor visitation is allowed for all residents regardless of vaccination status. Prior to this update, indoor visitation was heavily dependent on a county's positivity level as well as a facility's positivity rate and whether or not they were in outbreak testing. And that has changed significantly, as you can see here with that bullet point. The next bullet point that also is a significant change is the ability to have indoor visitation during an outbreak. There is, of course, some guardrails to that and what a facility needs to do should they identify a positive case and follow those testing requirements. But it does provide for an avenue if criteria is met for facilities to continue indoor visitation during an outbreak. The next bullet point is not new, but it is something that we do continue to reiterate, and that is that compassionate care visits should be happening at all time, regardless of a resident's status, a facility status, the county positivity rate, the resident's vaccination status. None of that criteria should hinder a compassionate care visit. The last piece of information is that both of these visitation documents now incorporate the idea of vaccination status for residents and the ability to expand on visitation based off of vaccination status, specifically when it comes to personal touch. That concludes my portion, and I would be happy to stand for questions now or at the appropriate time.
Thank you. If you will hold for questions, we have a question from Representative Lynn, and then I have a question. Representative Lynn.
Thank you, Mr. Chair. I just have a question about what determines an outbreak. Is that a countywide outbreak or is that within the facility?
CMS defines it as a new onset, and I I don't want to speak and not give you the right definition, but I can certainly get that definition that CMS has and provide that to the committee.
Okay, thank you. Thank you, Mr. Chair.
My question is, these new visitation guidelines are great. And we heard earlier from some facilities that are opposing HB 2062. And the crutch of HB 2062 was to allow visitations for family members. This appears that HB 2062 wouldn't be needed, but if that is true, why do we still have facilities, and I can give you a name of a facility, that will still not allow in-person visits or compassionate care visits, and people have to see their loved ones behind a plexiglass?
I will say that in the guidance that CMS has put forth, when they discuss indoor visitation and they talk about visitation areas, they do talk about needing to adhere to the core principles of COVID-19. They do not discuss the other physical elements of an indoor visitation area, but they have provided a CMP program that allowed for pretty specifically plexiglass to help facilitate visitation areas in facilities. And they, within the guidance, don't provide anything that doesn't allow for that plexiglass and or for them to set up visitation areas that have maybe some more stricter protocols than those core principles, but would be in line with core principles for lowering transmission.
Without the passage of HB 2062, what would a constituent have to do to get a nursing home to let them see their loved one?
I would suggest they contact the nursing home and start there. And if it starts off with an issue, I would ask that they see if the facility is willing to share their policy and procedure on visitation. And then based off of that policy and procedure, if the facility is willing to share it, if they can identify that their visitation is clearly being violated based off of the visitation guidelines that are out there, as well as that facility's policy, I would request that they then contact our complaint hotline and do a report with our complaint hotline so that we may then triage it and then send surveyors out to do an investigation, and we can begin our process of investigating that for a deficient practice.
Okay, thank you very much. I do not see any further questions for you. So Scott?
Okay. Thank you, Lacey. Thank you, Mr. Chairman. Maybe just to cap Lacey's comment there. So we have the guidance does try to open the doors a bit more, certainly more than they were at the beginning of the pandemic. But it does leave some decision making up to the facility of what they can support with in terms of their infection control practices, staffing, things like that. So it is important to figure out what the facility's policy is, sharing that with family members and loved ones who want to visit, so it's clear where the rules are. And then, of course, for us to look at complaints and investigate those things, so that, I mean, that's how you define the rules. I think your question about what the House bill would do is you couldn't have any restrictions at all on visitation, and so even with the CMS and our guidance, there's still some opportunity for facility level policy making, which I mean, that's a policy choice for you all, but I think that's one of the other distinctions maybe to draw out.
Okay, we have another question for Representative Landwehr, but I want to make a quick comment on that. If facilities don't want the legislature to step in, and they don't want House Bill 2062 to happen, they need to then be more flexible with our constituents and allow them in when there is no risk for COVID in that facility, so they can see their loved ones, especially when they're in the later days of their life. To me, it's just very, very, makes no sense. And it's very ridiculous to me that we still have that situation going on. Mm-hmm. And hopefully we can get that to an end. But that's just my comment. Representative Landwehr has a question. Representative?
Thank you, Scott. And we talked about this last year, and I believe it was you that had said that we might have some folks that have had to go out to a couple of our nursing homes with a concern that we have on their financial stability, not because they're doing something wrong, but we're just keeping a closer eye on it so that we don't have any more nursing homes in receivership. Can you give us an update on where we're at on that, please?
I think what Lacey talked about in terms of returning to a normal survey schedule and cycle, we look at more factors than we were before in the kind of the heart of the pandemic, where we were primarily focused at CMS's direction on infection control practices, hygiene, things like that. So I'd say we're looking at more factors like our facilities paying their vendors, are the staff. Is there an adequate number of staff, and do they have the supplies they need? Those kind of leading indicators of maybe financial problems. We're going to look for more of those things just in kind of doing our routine business. But and I think even in some areas where we did focused infection control work and found problems there, that was an indicator of maybe some other financial issues of there either wasn't enough funding coming in, census was dropping, and not enough revenue. So I think the doing the regular work finds those things, maybe by detecting it in other areas of the operation. But yeah, I think getting back to more normal, more routine kind of survey work, annual survey work will make sure we're looking for those kinds of things.
Okay, but do we have any right now that we're still out there that we may have concerns on because they're sitting on the edge?
We've got one facility that has a temporary manager that was related more to the infection control practices that was imposed by CMS. That's the only one that I'm aware of that we're have that higher level of intervention in to keep it sustainable.
And then just to kind of follow up with where the chairman was at on his questions about the visitation within nursing homes. In order because I think it's probably a handful of homes that may be having this concern, because I don't hear a lot of that concern expressed down here in my area. But I know that I have heard it kind of scattered across the state a little bit. Is it possible as legislators for us to help maybe shortcut that a little bit, and rather than go through the complaint process, which we heard about just a little bit ago, is that, because the nursing homes, I guess from my perspective is, they came to the legislature and were concerned about, liability issues, and, we got right on that and we helped address that for them.
Mm-hmm.
And I think that they have to remember who it is that they serve, and they're serving those patients in there. And when they're serving those patients or clients, whatever they want to call them,
Sure.
They're also serving the family, because many of the family members play a big part in the wellness of their client. So
Right.
perhaps that we could give you or someone else a direct call, and let's talk about specific nursing homes instead of putting them all in one lump as perhaps not
Sure.
being friendly actors.
I think that's very fair. I would say, the benefit of having a complaint gives us something to go and investigate and kind of get more sides of the story, which, I'm not suggesting anybody's not telling us the truth, but we need to figure out what's going on at the facility, why they're being more restrictive, or what their conditions are that may not come across to the family. I guess the more of these cases that I've been involved with, clearer communication would certainly help, which is probably overused excuse, but the facility being clear on what they're doing and why they can move. I would say one of the things that I'm extremely proud of that we did in our guidance was direct facilities to involve families and residents in care planning specific to visitation, to talk about what kind of visitation do you want, what can we do as a facility, and make that work and really negotiate it. And I'm really glad we included that. I think that focused on the person-centeredness that we really want to strive for. The more we ask about, how was that work done, we see where there's some gaps there too. So I agree. I don't think we want complaints to be the primary source. That does give us some other tools that we can exercise then. But I appreciate your comment and the spirit of the question.
Let me follow up on that just one step further then. Is there a ding that can occur if complaints are coming in on nursing homes for such as visitation? Like we see that can happen with hospitals. So if we're having to file claims or a complaint, then how does that impact them in the future?
There are specific, we call them tags, but citations that we can issue related to visitation. I don't, Lacey might help me. I'm not aware that we've done any of those directly, but that's what we do go look for and evaluate when we're doing investigations. But I don't think we've written any specifically, but Lacey, are you aware of any that we've actually written? But there is to your question, Representative, there is a tag that we could write specific to visitation.
That's correct. There is. And it is something that we have not cited here in Kansas yet. It is something we do look for. We have had some serious discussions while out on survey with our partners at the regional office with CMS, whether or not we had enough evidence to support a citation, but have never reached a level where CMS has supported the written findings for that citation.
Okay.
Can I make one comment to the complaint process, just a logistics? The one benefit to having the constituent themselves reach out to our complaint department is our complaint department then is able to get that firsthand account from that constituent on their interaction and also establish that good line of contact. And that would be something that would naturally have to happen in the process later if it came from a representative. And I certainly would welcome any concerns from anywhere, but just in the idea of expediency, having them call directly to that complaint hotline and getting that established contact and communication set up is, I think, probably the most expedient way.
All right, that's great information. Thank you.
Point. Thank you.
Yes, thank you very much for that information. And just to clarify, and I appreciate Representative Landwehr clarifying, most adult care facilities, nursing homes are doing an outstanding job, and we just really appreciate that. But there are a couple or a handful that still are making things difficult for family members, and that's the issue. So,
sure.
Scott, I appreciate that. And, you know, for some reason, Scott, I don't know why when we always get to you, we're always short on time. So.
I'm not taking it personally, Mr. Chairman. I'll try to be as quick as I can, but I've got at least one question for Representative Ballard that I need to address. But maybe just to tell you what's in the slides and then go as quickly as I can. So we are asked to talk about updates on recruiting and retaining staff at Larned State Hospital related to some salary increases that happened last year. So we've got the vacancy rates there. You can see on the right-hand side of the slide since last June to the end of March, we did have a little bit of an improvement, but we're still at 33% or so of our total number of staff vacant, and that a big share of that's in our direct care staff, the MHDDs, which are mental health technicians and licensed practical nurses and technicians. That hasn't changed a lot. We've seen some progress on the security side, but we're still recruiting and trying to fill positions at Larned and keep people there as well. A couple of the next slides talk about efforts that the hospital's taken to recruit and retain folks. Lots of effort in advertising around the state, not just in Larned and Pawnee County, but all of central and southwestern Kansas. I guess I stopped on this slide because there are a couple of new things that we did update. The second bullet down, we do use a lot of agency nurses and staff to supplement our employees. As you've probably heard from the nursing facilities, those are expensive staff to hire and keep, but it is pretty critical to us being able to maintain our operations. And then the bullet points about our training programs. We cooperate between the two behavioral health hospitals at Larned and Osawatomie to train some of our own staff to advance their skills so they move to a different job role, but also more pay. We train them internally and then keep them on board. And we've graduated. That slowed down a little bit with COVID, but we have graduated 3 LMHTs, licensed mental health technicians, out of that program and filled those positions this year. And we do have a retention team that again, was suspended for a while, but they've started to work on other ways to make the work-life balance, the work environment more positive at Larned. The other element here on slide 33, House Bill 2007 does have a proviso that would direct Larned to raise the starting salaries to at the same level as Larned Mental Health Correctional Facility, which they share a campus. The correctional facilities, well, depending on where you are, but just across the street from the hospital. And right now, the base pay or starting pay for a correctional officer at Larned is $18.26 an hour, and our mental health developmental disability technicians, their starting wage is $16.16 an hour. And that's higher because of the executive directive action that was taken a couple of years ago. So we have run the estimate, taken all the staff, it's 378 positions, and to raise all of those to the 1826 or make a corresponding change for people that have maybe a little bit more longevity to give them the same percentage as about $1.6 million to do that. That would certainly help balance any of the transitions that folks, as if they could work at either campus and make a little bit more money at the correctional facility than they can at the state hospital. It would certainly address that. The other factor we'd have to think about then is compression as we raise the floor up. Do we need to move other positions as well? And there are some areas that we'd want to address there that maybe don't have an equivalent on the correctional campus. The last part of the Larned discussion, and we've shown you this chart a couple of times of our number of mandates. So one indicator that we look at of how we're doing on recruiting and retaining staff and the impact that has on care is how many times a day we have to hold somebody over from the shift that they're working to carry on to the next shift. And so that's what this shows back to January 1 of 2019 of the number of times that happens on any given day. And if you look kind of in where the dots start to sort of join together, that's around 45. So 45 times in a given day, we've had to hold somebody on to the next shift. That's where we were back in January of 2019. If you can really pick up the dotted line that shows the trend, it's on a downward slope, so that's positive. But there's still an awful lot of mandating happening every day, and that's all related to staffing and has an impact on quality of life for the staff and quality of care. On to the lifting the moratorium at Osawatomie. I updated these slides to kind of give you some progress since February. Again, our plan that Representative Ballard mentioned has a combination of using bed capacity, adding capacity at Osawatomie on the campus, and then increasing the number of community-based inpatient psych beds that would be available. So first talking about those regional diversion beds, or what we've now titled through Medicaid policy, state institutional alternatives. The budget, the approved budget for this year's got $5 million for those beds, in addition to some funding that was already in the approved budget. And we've been putting a lot of effort into recruiting hospitals to take on that designation of state institutional alternatives. We've met with Kansas Hospital Association's Behavioral Health Committee, which has a number of hospitals that, as members on that committee, that have psychiatric beds, other people who work with hospitals on psychiatric care issues. We presented our plan, kind of the process for getting enrolled as an SIA, what we're thinking about in terms of the rate structure, the process for admissions, and work through them. And just as a result of that conversation with, I think there were maybe 15 or 20 hospitals or inpatient folks on that committee, we got 2 or 3 calls or outreaches that we didn't expect of people to reach out to and kind of answer some more questions and move a little bit further down the road. We sent targeted messages, email messages to 30 hospitals that had been referral sources to the state hospitals, or that have had inpatient psychiatric beds. We got, again, about a dozen responses to those 30 sort of cold email calls or email messages. with looking for more information or focused conversations, and some of those have happened. We've also created some marketing materials and a specialized web page on the KDADS website to make the information available so that people can see what the enrollment process is, where those forms that they'd have to fill out would be. So right now, I mean, that's a lot of effort. It's materialized into one completed contract for an SIA provider and 2 more that are in process. We've got to get and maybe 5 to 7 more very likely folks that if we can get through the process would sign up and create some of that regional capacity that we've been talking about. We've also got the construction working based on the capital improvements budget. And so on B2, which is the unit we're remodeling to accommodate some patients while we do other remodeling around the campus, that's all complete. We're planning to select a contractor. I think it may be next week, still in April, to start that construction, and then we'd be able to occupy the space by September of this year, which I'll come back to and talk about with the proviso language for lifting the moratorium in October. East Bethell is the larger project to remodel space for certified, to serve certified, or to be CMS certified. The drawings are getting close to being done. We think we'd start construction in October, and then it'd take another year or so to be able to occupy that space. That may be the other factor we'd want to talk about, depending on the timeline for the moratorium. But we're making, from where we were, even at the beginning of the legislative session, we've made good, deliberate progress meeting the timelines that we had in place. So again, House Bill 2007 does include a requirement to lift the moratorium on voluntary admissions in October. To do that, I put some details in here about what the proviso actually says, that we can't, it ties to our appropriation to lift the moratorium and not impose another one in fiscal 22 or fiscal 23. And so we're working on evaluating what the impact might be of that timeline shift. It's again, our plan was to lift the moratorium in December or January as we got the space finished on B2, staffed up, and then kind of evaluated where we could move some patients around. Moving that back to October 1 is not a lot of change. And we'll have the B2 space done, but just barely. So there's maybe a little bit of concern about the timeline for that. I think the bigger concern overall, and you've already heard this, so I don't mean to be a broken record, but is staffing to serve those patients. We've got to have enough staff to staff that new unit and the existing units that we have to keep them at the current capacity. And so we're posting positions. We're looking to fill them. The wage issues are the same that the PRTFs are having that you've already heard about. So I won't belabor that. But so there's a couple of factors that are concerning about October 1 as a date. It's not impossible, but I would feel a lot more comfortable being saying something definitive if I had a better sense of our ability to recruit and retain staff at Osawatomie. And honestly, our hiring path is about the same as it is at Larned in terms of finding people to fill those vacant direct care positions and nursing positions. Those are the two kind of critical needs. So that's the bulk of my presentation. I'm happy to answer questions. There's some other slides in there with data that we present to update the committee on it, but I won't walk you through those in the interest of time.
Scott, thank you very much. And I do not see any questions for you from the committee. And thank you for as always, your expedited overview. It's still informative and you get to the point, and we sure really appreciate that. So committee, we will now turn to our last presentations from the MCOs. First up is David Livingston, CEO of Aetna Better Health of Kansas. David, welcome to the committee. And just as a final reminder, you guys are the only ones between us and going home. So.
Great. Well, thank you, Mr. Chair, members of the committee. I will keep up my streak of being very brief. You have slides in front of you, and I do want to, before we go to this first slide, I know that there was a question asked about PRTF and what the MCOs can do on the hourly wages. While we don't directly control that, we pay the PRTFs, the Medicaid reimbursement rates, but we would certainly be happy to sit on any work group or work with any individuals to help solve that problem. And we can probably bring expertise and what's going on in other states. So we're happy to contribute in any way we can. But unfortunately, we don't directly control the wages that our provider partners pay. So since I went first, I got to say that, I guess. As always, I start with a member story, and in interest of time, I won't read through this. I know you guys all have this, but again, I just want to, when we share these stories, it's not about bragging about what Aetna does. All of the MCOs in Kansas do great work every day taking care of members. We could spend 3 days sharing member success stories, and every one of us is committed to improving the lives of those we serve. And certainly even during times like this last year, it seems like I was talking to somebody earlier this week. It seems, I remember the Bethell committee right before we closed down, and who would have thought that so much had transformed, and the collaboration that occurs between providers and the other MCOs. It's been fantastic, and I think we've seen some great work. We'll go to the next slide just to give some data on supporting members. We have at Aetna. We've delivered a lot of care for COVID, and these numbers are really eye-opening. We recognize the strain and stresses put on our provider partners, but as MCOs, we've worked very, very collaboratively, making sure that where we can release the pain points for our provider partners, we do that. And everything we do is with the members and the patients at the center of what we do. This slide shows 1,800 members have been vaccinated. Part of that's because, as a Medicaid population, a lot of our members are kids. And also it's been, a lot of our members are under the age groups that are eligible for vaccination. So that has opened up. I can assure you that every one of the MCOs is working very hard on this, and we will pass that we will reimburse the providers that $40 that was referred to earlier. We are also collaboratively working on a performance improvement plan with the state of PIP, focus on vaccinating our members and communicating to them. Some specific things that we at Aetna are doing is our care managers are all reaching out to the high-risk members, and we're trying to find solutions for those who are home-based. We're also evaluating how can we support clinics throughout the state to augment what's being done. And I know that all the other MCOs are doing the same, and we're trying to collaborate as we do this. We can go to the next slide. We've talked a lot about telehealth, and I thought it'd be really interesting to share a couple slides that really kind of put a very interesting picture. So the top graph is 2019. As we can see, basically there was no telehealth. But the bottom graph shows same month the next year. We had that surge in April, when everything closed down, and then people started going back to doing visits. But it's really kind of steadied at that. About a little over 15% of our visits now are done via telemedicine. So it's something that has really changed the landscape and has really increased access throughout the state. And a slide I have, if we can go to the next slide. This is overall telehealth utilization by county, and it ranges an increase from, and I know these numbers are really, really small, so rather than look at the screen, it's probably easier to look at the handout. But anywhere, we've seen an increase anywhere from about 2% to 35% on the county, on a county basis for telehealth utilization. And I'm happy, offline, if anyone is interested in your own districts or any particular areas of the state, we can provide you that backup data. What I do caution is that some of these counties, the denominator is really small, so the percentage might look really, really big. But overall, across the state, we're seeing significant increases. And the next slide, I focused on behavioral health. And that's really where we're seeing the increases in telemedicine. And a lot of these, where we're seeing this increase are in counties where there has been access issues. And what having the telehealth for behavioral health has enabled individuals who maybe weren't able to get timely access to behavioral health care in a more timely basis as a result of having the telehealth options. We can go to the next slide. One of the things that I had talked about a year ago and year and a half ago was that we were starting our provider advisor groups. And I wanted to follow up with that because I told you guys that we were doing this, and I never really had followed up and said, I said we've started them. But, you know, these have really started to gel, and we've continued these virtually throughout the pandemic year, and we look forward to having face-to-face meetings again with our provider partners. But, you know, a lot of it's been focused on how do we improve our processes. So really taking feedback from our provider partners. And one thing that had come up in a couple of our provider work groups, our provider advisory councils, was, quite frankly, our credentialing process was confusing. And so we worked very carefully with them to help really put it in a way that they could understand, that forced us to increase communications with the provider, help them understand the exact, you know, what is credentialing, what is loading period, you know, what every piece of the process is. So really help draw out a process map and help them understand that, increase transparency on our part so that they could understand where they were in the process. And if there were delays, understanding why there was delays. And so we've actually posted those on, you know, as a result of that feedback and their sign off of this process, we've posted this on our bulletins, and we've received a tremendous amount of positive support for this. And we look forward to continuing to work with all of our provider groups. We have one set up for physician offices. We have hospitals. We've done each provider type. We're in the process of trying to get those together. This is really valuable experience for us. And I just want to share with you, making this real for you, because we talked about doing this and wanted to demonstrate what we've done. And finally, I know we've talked a lot today about, you know, getting people into community settings. And I wanted to just kind of review our transition program. And I know that all the MCOs have these programs, but all of us have transition specialists who work with our members who really want to get out in community settings. And we continued this work even with the pandemic. You know, this is where we collaborate with our members, helping them develop a personal plan. It's not our plan. It's not a provider's plan. It's the member and their family plan to help them get back into a community setting. We establish goals, and then we have service coordinators who work with various facilities so that we want to have that consistency so that the facility care coordinators, social workers know us, and so that we can make this transition much easier for the member. Also, these assigned care coordinators, service coordinators understand the geographies, and they understand some of the other social determinants of health that might be required in those geographies. So we really have set up a specialized model. And then, you know, it's more than just getting somebody out in the community. It's making sure, do they have housing needs? Do we need to, I know we talked about home modifications, other accessibility, setting up utilities, getting them furnishing to start a home. These are all the things that we work very closely with our members to get. We can go to the next slide. And again, we have a very, you know, while each member is assigned to they have a care coordinator who works with them, but that care coordinator works with a team that's centered around our members. We have the facility and service coordinators, the transition of care coordinator who works with that member. We also have what we call systems of care colleagues. These are the individuals who have relationships out in the communities we serve and help connect people with non-traditional, what I would call non-traditional, what people don't normally think of as a Medicaid benefit. You know, this is helping people with housing, helping them get that furniture, transportation, utilities help, all that stuff that really is a value of a managed Medicaid program. And then we also have our medical directors, nurses, and other clinical leaders, so that we're making sure that our members, when they are released, or when they move into the community, that they have the supports, understand the care, and are still receiving high quality care and have access to that. Next slide, please. And then just, you know, like I said, you know, we continued this through the pandemic. Nearly 100 individuals we were able to transition, even in the pandemic. You know, when I know it seems like time stopped in 2020, but, you know, we did take care of our members. We focused on that. And we also leverage alternative technology, made sure that virtual worked for them, and we continue as these members have moved into community settings to communicate with them virtually. And we are really looking forward to face-to-face. I know that I think our care coordinators are targeting in June to start beginning to do those face-to-face visits again with our members who are comfortable with it. So that concludes my slides. I know I talked very fast, but I want to give time for questions as well as my colleagues at the other MCOs to talk. So I will, that concludes mine. I'll stand for questions.
David, thank you. And we do have a question from Representative Concanon.
Thank you, Mr. Chairman. Thanks for your presentation, David. I think we've come a long way in a year and a half, and appreciate all the time and effort you've made for the improvements in your company. I'm guessing you probably were listening earlier, but there were some comments or some questioning about sedation dentistry. And just wondering if you have any response to that, if you heard that, and if there's anything that we need to do to provide more, to have more dentists taking Medicaid.
Yeah, I think at a high level, and certainly I will do some more research. But I know that it is a challenge. It's there's limited dentists in the state of Kansas, especially once we get out into more rural areas who do this. We have, in the last year, actually increased our reimbursement and done special contracting with these dentists. But I think it comes down to a supply of dentists issue. We can certainly follow up with you and kind of let you know where we have dentists and where we see gaps. But again, I think it really does come down to a supply, because this is a very specialized niche for dentists. Not every dentist will do this.
Yeah, thank you. I'd appreciate some follow-up. I know it's difficult enough to find someone who will take Medicaid, but then when we've got needing the sedation for the IDD participants, that I just think that's really difficult for them to drive such a distance. So I'd appreciate any follow-up you can give me. Thank you.
Thank you.
Okay, David, I do not see any further questions from the committee. So thank you for your presentation. Committee, we will now hear from Michael Stevens. He's the president and CEO of the Sunflower Health Plan. Michael, welcome to the committee.
Thank you, Mr. Chairman and members of the committee, and it's my pleasure to be here. And I would also like to begin with a member story, or what we call a mission moment. And this really reflects much of the discussion that the committee has had today. The human side of the advantage of vaccination and the ability to return to a much more normal visitation schedule, particularly for our members in long-term care facilities and assisted living facilities. And we continue to receive positive feedback from members and families about the ability to begin seeing one another face-to-face again. That's not only important for compassion, but in some instances, particularly those suffering from dementia, really important for their quality of life. And so next slide, please. Here we wanted to share, similar to what David shared, what we're seeing in the ongoing trends of the utilization of telehealth. This is maybe just a slightly different way of portraying our data, but really the same thing over time from 19 through 20. You can see that telehealth visits just were almost non-existent back before COVID, and there was a very, very quick adoption as early as April. It has settled down now, but continues to be a steady part of the way that we reach out. We're also seeing more and more members who are happy with the ability to have a telehealth visit as an alternative. Next slide. This looks at the same data, but as a percentage of all claims. And again, you can see that same pattern. And then moving on to the next slide. This is what we would call a heat map of the percentage increase in the use of telehealth services in all of the counties across Kansas. And you can see there was significant upticks in certain areas compared to others. Certainly, some of the more rural areas of the state continue to have the challenge of the access of high-speed internet, which impacts the ability for telehealth to be successful. And that's a problem that we continue to look at what role we can play in trying to improve that. But virtually all parts of the state showing a significant increase in the use of telehealth services. Next slide. I just wanted to quickly update you all on our efforts. It's back one slide, but that's all right. We can stay here on Project Search. Project Search is a program. Oops, there it is. We'll stick with this one. We have enjoyed great collaboration within Kansas throughout the year in promoting competent care during COVID, particularly in the care of our members with disabilities. CMS sponsored a webinar, which coincidentally occurred today, and Sunflower Health Plan was selected as one of the speakers to outline the great work that was accomplished in the state of Kansas in quickly pivoting to caring for members with disability. And it really, while we had the opportunity to speak, it really reflects tremendous teamwork between KDHE and KDADS and all of the 3 MCOs, along with all of our contracted providers to make this happen. And we were honored to be able to speak to this national audience today on the success that we had as a state. Next slide. Now here's Project Search. Project Search, moving on to the next slide, is a program for which Sunflower is the statewide coordinator. It's a program aimed at providing training and orientation to assist individuals with developmental disabilities in finding competitive employment. And we have led this effort for the last 5 years. Currently, we offer this in 5 project sites across the state, or in 13 project sites across the state. We'll be adding a new one this fall in Wichita in partnership with the Mays School District and Via Christi Health System. And then in early 22, we'll be adding one in conjunction with the Kansas School for the Blind in Kansas City. This program has had tremendous success. We have seen 75% since the inception of the program in all locations. 75% of the program participants achieve competitive employment at the end of the training program. This includes not only training in school, but on the job through 3 internship programs for each person to help them find their right niche, and support on the job in order to help them be able to learn the skills required and be successful. And we're just really pleased with what this has done to improve the quality of lives of those we serve who have developmental disabilities. And next slide. This really concludes what I wanted to share. Representative Concanon, you asked earlier again about efforts on sedated dentistry. The only thing I would add to what David shared is that it becomes further complicated by the fact that in order to achieve this access, it requires not only a dentist, but typically requires an anesthesia provider. And for the anesthesia provider to find it feasible to be available, often they will require a minimum number of patients in a block in order to make their staff person available to leave the hospital or surgical center setting where they may be working to come to the dentist office. By definition, that contributes to often these services being located in a few locations where there can be a larger number of patients served. But it is an ongoing challenge to improve access for this part of our population that we serve. We too, along with the other MCOs, have increased our reimbursement rates to these providers to help them address that issue. But that continues to be a challenge that we work on. That concludes my remarks, and I'm happy to respond to any questions.
Michael, thank you very much for your presentation. I do not see any further questions for you. So, committee, we will now move on to Kevin Sparks, CEO of United Healthcare Community Plan. Kevin, welcome to the committee. Kevin, are you with us? Kevin, I believe you are on mute. Kevin? Kevin, I was reminded by Representative Ballard that you are the last one on our agenda, and you are the only one standing between us and that door right there. And so.
Yes, and I was talking on mute, so that was very good. You didn't hear my quote. I was saying, from Talladega Nights, Ricky Bobby says, if you aren't first, you're last, and so I think that's the position we're in. So I will make this quick and continue to move on. We've marked an important milestone in COVID-19 since the last meeting. We crossed over a year, and one of the things I wanted to quote was to make sure that we emphasize what Secretary Norman and Secretary Howard have talked about, and that is the additional services that the MCOs have all brought to Kansas during the pandemic. And that continues to happen. And one of the things that I'm going to highlight to you is Adventure Dental. And I'm fortunate that we're talking about dental today. We had an Stop COVID event hosted in Wyandotte County at Adventure Dental. And Adventure Dental is a really innovative partner in Kansas. They have locations in Topeka, in Wichita, and they just opened a facility in Wyandotte County. And they do sedation dentistry. And they focus on kids in underserved areas. And so it's a really good partnership for us. We had an opportunity to help promote the services that they bring to Wyandotte County, in addition to handing out Stop COVID initiative, where we gave out boxes of food, hand sanitizers, masks, personal paper products, etc. Next slide, please. Some of the quotes that you will see, I won't read these to you except for maybe the bottom one. It felt great to be able to work together with Adventure Dental to connect in a tangible way with people in a community that experience food shortage and income disparity. To be part of an initiative to help fill some of those gaps while at the same time bringing awareness to an excellent part of our provider network was amazing. So again, a very well-attended event, and again, emphasizing dental and underserved areas. Next slide. That's a little bit of a picture. I wanted to make sure we had a lot of pictures. Sometimes it's easier to explain what we're doing when you can see it, and the food boxes are there. And then next slide. You can see the contents of it. And then I want to focus a little bit on, the partnerships that we do to bring them. We've partnered with harvesters to build the boxes, and we gave away 3,000 of those and 5,000 health and safety kits in Wyandotte County. Next slide. In addition to that, so the big controversy I think that you hear about, you read about, should you or should you not laminate your vaccine card? We came up with a solution for that, and we've created a plastic pouch for your vaccine cards. And we distributed 6,000 of those cards across Kansas City, Kansas, in order to give those to people so that they have a way to safely display their vaccine cards. And I think in the future, I think we saw yesterday in the news that Pfizer, for example, will probably be offering annualized boosters, and you can obviously add those to your cards. Next slide. A little bit of some of the feedback that we got back from that initiative. And then finally, I think we talked a little bit about this before, but 10,000 surgical masks was an in-kind donation that we made in the state of Kansas to our FQHC partners. And we'll continue to look where we can to make a difference with respect to fighting COVID until it's beaten. So that concludes my comments for today, and we'll stand for any questions.
Kevin, thank you very much for that. You definitely made up for your muteness there. So I do not see any questions for anybody, for any of the MCOs remaining, and Kevin. So if there's nobody online with any questions, thank you very much for your presentation. Committee, we do have the approval of minutes that we have to address for February 19th, 2021. Do we have a motion to approve? Motion made by Representative Ballard, second by Representative Concanon. All those in favor say aye.
Aye.
Those opposed, no. That motion's carried. Minutes are approved. Committee, also, I think if you have not turned in your travel voucher, your payment voucher, make sure you've turned that in. And then our next meeting will be a 2-day meeting, and it'll be in our third quarter, so that would be July, August, or September. Is that correct? So what, if you wouldn't mind emailing Marisa with a preferred month, which works best for everybody, July, August, or September, and that way we can get that scheduled. Okay, and with that, if there's nothing else to come before the committee, we are adjourned. Thank you, everybody.